What are the chances of me coming in today and giving you COVID? We don't know the answer to that question. We don't know the answer to that question. So I think that's kind of important, right? Why can people get together? You can.
Yeah, I would think it's pretty important. Yeah. What's cooking, everybody? I am joined in the bunker today by my friend Dr. John Schneider, PhD. Dr. Schneider, to be clear, is not a medical doctor. He is a doctor of PhD. Smart doctor. Not the medical doctors aren't smart, but you get the point. He's a doctor he's got a doctorate of PhD in some form of economics. I forget exactly which one, but hard shit. Anyway, despite that little snippet you heard on the front, I can confirm that Dr. Schneider did not, in fact, have COVID. And we took the ultimate precautions before he came in. He was actually supposed to come in about 8 or 9 days before this, but he called me and said, Julian, I got back from Miami about 2 or 3 days ago, so I really should be quarantining. And I have a scratchy throat, so he was a little spooked. And so I was like, of course, let's punt this one. But he got, as he'll describe in this episode, 3 negative tests throughout the week, was good to go. And somehow when he came down here into the night, developed a little cough that, again, wasn't COVID. But that probably had something to do with the fact that he drove down about 2 hours to be here at 10 o'clock at night on a weeknight and was here until about 2 a.m. like a savage. So thank you for doing that, Dr. Schneider. And it would all be hugely ironic if that had been the case and he had come down here with COVID, when in fact I was bringing him in here to talk about COVID. Now, Dr. Schneider is the CEO and founder of Avalon Healthcare Economics, which is a company he founded, I believe, in 2012 or 2013. And what they do is they consult on the economic side specifically within the healthcare space. And his previous company that he was a partner in, he sold along with his partners. So this is something that he has been eating, breathing, and shitting for the last 30 years of his life. And with COVID. It's also something that he eerily called a play-by-play on how this was going to go back in around mid-February. I spoke with John. I mean, it was like mid-February, maybe that last week of February, but I feel like it was around February 20th. I spoke with him on the phone, and he was the first guy to say something that made me go, whoa. He told me he thought this thing was going to last till at least July, which obviously looks incredibly wrong now because here we are. But there was nobody saying this at the time. Nobody that I could find saying, yeah, we're going to be shut down till July. He also went through exactly what he felt was going to go wrong and why, and that turned out to be awfully correct. So, being a guy who is very close with a lot of people who are medically working on this thing every day, and somebody who understands how the healthcare system in the United States works, I wanted to get a State of the Union on COVID and actually ask some hard questions and see what kind of answers he might have. And frankly, I think he had an answer for about everything. So in this podcast, we talked about Miami for about the first 10 minutes because he's a dual citizen of the Northeast of Miami, however you say that. He lives in both places, and obviously, Miami's a different world right now. We talked about that with Kevin last week as well, but wanted to get John's thoughts on it too. And then we spent about 25 minutes talking about John's background and the work he does, so you understand exactly what point of view he's coming from. But the rest of the way, that last, 2 hours and 20 minutes, 2 hours, 25 minutes was all COVID. And we talked about things like personal health choices and how that affects the rest of us. We talked about things like hospitals potentially declaring COVID deaths that maybe aren't so COVID-y. And we even talked about the vaccine in depth, which was a conversation I really appreciated because I know there is some hesitancy out there because of how quickly this vaccine was produced. I felt like Dr. Schneider gave a ton of reassurance, at least for me, but I'll let you guys be the judge of that. So this was a very good and, might I say, very, very important podcast. Anyway, if you're not subscribed, please subscribe. And if you haven't left a 5-star review with a comment on Apple Podcasts, and you can take a minute to do that, I'd really appreciate it. Thank you to everyone who has. And to all my people watching on YouTube right now, do me a favor. If you're not subscribed, obviously subscribe, but hit the like button on this video and hit that bell button right there so that I don't know if I'm pointing in the right spot right now where it's going to come up, but hit that bell button where it is on the screen and down below the video so that you can get a notification when I post videos on the platform. That said, you know what it is. I'm Julian Dorey, and this is TRENDIFIER. Let's go! This is one of the great questions in our culture. Where's the nuance? You're giving opinions and calling them facts. You feel me? Everyone understands this, but few seem to do it. If you don't like the status quo, start asking questions. You are, I think, the fourth person I've had in here in the last month and a half who was down in Miami for an extended period of time. When'd you get back?
Well, so you better get yourself COVID tested then. You get a lot of exposure that way.
Well, no, I haven't. The last three were, I guess, like 3 weeks ago, something like that. So I'm good now. But one of them had it while he was down there.
All right.
So he had just been getting over it maybe like a month before. He'd been down there for like 3 months.
Oh yeah, 3 months. Yeah.
But how long were you down there?
Well, I go periodically. So I go. I've been a number of times since the lockdown and pandemic and all that broke. But when I go, I only go for a few days at a time. So I don't stay extended period of time down there. This past Christmas to New Year's break was the longest time I've been down there in a long time. Since COVID.
Because your wife's down there, right?
Well, not anymore now because they let her work from home.
Ooh.
And actually just recently she found out she's permanent work from home. That's
No
a whole
kidding.
a whole other thing. Like you've got all these people now who are suddenly told, "Hey, by the way, you're permanent work from home."
Yeah.
And if they don't have a nice setup like you have here, they got to figure out how to deal with that.
Yeah.
Like I've got a couple. You've been to. You've done the Jersey City thing and all that. I've got, one of my employees just moved to Hoboken right before the pandemic.
And now they're thinking like, why?
Yeah, she got a tiny apartment in Hoboken, and now, I'm sure she's thinking, shit, now what do I do?
Yeah.
I've got to work from home in this shithole.
Yeah.
So,
can you pull that mic in just a little bit?
Yeah. Cool. So it's that better.
Yeah.
So that's a whole other thing. But yeah, I love Miami, and I think part of the thing that part of the appeal of Miami right now is that it's more or less, a sort of lockdown-free zone. You can go down there and just pretend life is normal, and I think it's bringing a lot of people down there. And I think what's interesting, and we'll probably get to this today, is that really a problem?
Yeah. Well, side note, just as far as not just people being down there because it's a whole different world. I want to ask you about that, but there's also this enormous bomb going off in Miami, no pun intended, obviously, where you just have San Francisco, and I guess started with the venture capital world like Keith Rabois, and then followed up with some of the actual innovators just going to Miami in droves. Because, by the way, a lot of these companies where even the highest talent works, they're going to be remote forever too. So they're even saying in Miami, you got Suarez, the mayor, going, okay, well, if you're going to be remote, why don't we set up pods of like the remotes so they all at least live in the same city? It's really crazy.
Right. They used to be called WeWork, didn't it?
Yeah, something like that.
Yeah, actually, I was on one of the flights to Miami. I can't remember when. Maybe it was back in June or something like that. I was sitting next to a woman in first class who looked like she was, she had tons of bags with her and everything, and kept her sunglasses on the plane. And it's just kind of an interesting person. So I struck up a conversation with her, and it turns out, just to make a long story short, her company had just told her, hey, we're not doing in office anymore.
Done.
Yeah. And this was in June, right?
Yeah.
So this is only a few months into the pandemic. So
amazing how fast they learn that.
Yeah, exactly. So she was working in New York City, living in New York City, and she's like, why should I keep my New York City apartment? $4,000 a month, for a closet in New York City. She's like, and she didn't know anything about Miami. She's like, I got online, I started looking at different cities, And I just moved to Miami. I just packed all my shit up and I'm moving to Miami.
Just herself.
Yeah, by herself. She doesn't know it, and she's like, what's it like in Miami? I said, I think you're gonna like it.
You're gonna have fun.
Yeah. But I was wondering on that flight. Again, this is months ago. I was thinking, I wonder how many of these people there are who are just,
There's a few. I mean, there was an article that came out over the summer. I know I've talked about it on a couple podcasts, but it's been a while, where a longtime New Yorker, James Altucher, who's like big on LinkedIn, he wrote this piece on LinkedIn that then got reposted in the New York Post. It was called, I think, New York City is gone and it's never coming back. It was a really scary piece, especially if you love New York like me. And I think that some of the points he made in there were very on point. And for now, they're a reality. And I think that there are some dangers to New York not being what it once was. And I also think that there is going to be a delayed period of time here, and it could be 5-10 years before New York is really back to what it was. But the final point, I'm just not really sure about. That said, he was a guy that went to Florida. He had lived in New York his entire life. He was raised there. And then he was like, you know what? It's turns out it's sunny down here. It's pretty warm. It's pretty wide open, and things are. I mean, I guess even back then when he wrote it, August, it was very open as far as Corona goes.
Yeah.
So you mentioned that already, but I'm seeing Instagram stories of friends who live down there, and they're going to clubs and stuff, and it's just no mask, just wide open, and I kind of envy it. But is that the norm or?
Well, I mean, no, that's a good question. First of all, I'm not really that much into the club scene in Miami, so I'm probably the wrong person to ask that question.
We'll let you get away with that.
Yeah,
I see the little wink across there.
Yeah. Thank you. This is public, right? With the mic's hot here. So I think the short answer to your question is yes, it is like that. Because I follow some of the influencers in Miami just so I know, like, if there's a new restaurant, what does it look like? Is it hot? Is it a cool place to go to? Is there a scene? I do. So I follow some people so I sort of get a good sense of what's going on down there. And these influencer type people, they're out at the clubs and the sort of more. Miami's probably a little bit more like what New York used to be in the sense that they have there's a lot of stuff. There's a lot of real estate between restaurants and clubs. There's these these sort of restaurants / lounges that become kind of clubby toward the end of the night. A lot of restaurants now have DJs. And so they're sort of like this middle ground. And I guess I'm mostly familiar with that middle ground, but the middle ground is actually, like, by New Jersey, New York standards, it's pretty cool, like pretty happening. And that stuff's all wide open. Like it's wide open. They're doing a little bit of distancing with tables, but even that is pretty minimal. People come in with, it's just kind of similar. There's, some masking up required, but for the most part, I mean, it's pretty wide open. That state's just decided, you know what, we're going to be a little bit like, like Sweden. We're just going to, I don't think they thought it out as well as Sweden did. Yeah. But I think they just decided, let's just give it a shot. As you know, like Florida, the entire state, incredibly dependent on tourism.
Yeah.
So I think from their perspective, they probably thought, if we do this, if we shut down, it's the death of us. Yeah. And also, excuse me, Miami, probably more so than any other city in Florida. But Miami's an incredibly international city, and they get people from all over. I said to my wife when I first started going, she first started bringing me down there. She's from there, so when she first started bringing me down there, I told her this city's more international than New York. You get that feeling when you're walking around. It's almost
a big statement.
Yeah, I know. It's but most of the people down there are from somewhere else. And when I say from somewhere else, usually from somewhere far away. There's a lot of Eastern Europeans. There's a lot of South Americans. There's a lot of Western Europeans. There's a lot of Canadians. There's a lot of Mexicans. The border countries. So it's a real melting pot in the true sense of the word. And I think from at least from Miami's perspective, and I think the state for slightly different reasons, They don't want to let that go. Like and those people are integral to the economy. They bring with them a shit ton of money.
Yeah.
And they buy expensive apartments and expensive cars, and they go to restaurants. They just drop money everywhere. They sprinkle it all around the city. And they didn't like the alternative to that. And then the rest of the state, of course, is mostly old people, retirees and so forth. And then you've got just your regular residents. And those, putting aside the regular residents, the older people who flock to Florida are also coming from other places. And they didn't want to, keep those people from coming, like the snowbirds, let them come.
Yeah.
Because the snowbirds come every year, and they spend an ass load of money when they're down there. So that's one of the reasons I think Florida took a different stand. But I think it's interesting to see what's going to happen. When the dust settles, what was everything worse in Florida than it was in New York in terms of death rates and hospitalization rates and things like that? And
I want to ask you about that directly, because you are somebody who you're qualified in more ways than one, and more than any person I've had in here to speak on this entire topic as a whole based on what you do. So before we get into it, can you just walk us through exactly what the story is with Avalon Health Economics and what types of work you guys do in the healthcare space so that the audience has an understanding?
Oh, yeah, sure. So, yeah, I mean, this is weird. I would expect that your audience doesn't know a whole lot about this space in general because it's a very niche space.
Yeah.
So let's start with drugs and devices. So medical devices, everything that's in a hospital, drugs, anything that you take, not so much over the counter, but any prescription drug, all of that stuff undergoes at some point some sort of economic evaluation these days. I mean, that wasn't true 10 years ago, but nowadays there's some sort of economic evaluation, whether it's a return on investment done internally by those companies that produce those things, or it's an insurance company saying, hey, I want to know what the bang for the buck of me spending money on this thing is going to be. Or if it's international, it's the health system. So the National Health Service in the UK wants to know, we're not going to reimburse anything or pay for anything unless it has proven value. And so value consists of both money and effectiveness combined. So I think, if you look at the healthcare industry 30 years ago, 20 years ago even, there wasn't a lot of concern about value. There was only concern about effectiveness. And if it was effective, we'll find a way to pay for it.
Right.
And that's just, not the case now. So my company just kind of fits into that groove. And we do evaluations for medical device companies and for pharmaceutical companies. We do these economic evaluations to see sort of bang for the buck for that device or for that drug. We work for small biotech companies and stuff like that. And we also do policy work. So,
that's interesting.
Trade associations will contact us and say, hey, there's this new law. Well, for example, the Affordable Care Act, right? That's the most recent sort of big ticket.
Because I talked with you about that once. This was a couple of years ago, and you were walking me through all that. And I think I'm a good example of it for the general American because our eyes glaze over when we hear this stuff.
Yeah.
Healthcare, when you look at it, money and healthcare are two things that literally every person in this country has in common because you need to protect yourself and you need to be able to have money in the economy. Right. And they're probably the two topics that so few of us, myself included, especially on healthcare, actually understand and know about. It's wild.
Yeah, it's a lot more complicated than I think a lot of people think, and which is why companies like mine can survive or thrive because there's this void of sort of people who really have a deep understanding of how all these pieces fit together. The U.S. healthcare system is incredibly fragmented. I talk about, the expression, the right hand doesn't know what the left hand's doing. That's big time true in healthcare. Like the pieces of the puzzle have no idea what's going on. In fact, not to get too far off topic, but the opioid epidemic, which prior to COVID was the talk of the town, right?
Yeah. Should be again too.
Oh yeah, it hasn't gone
on.
away. Like very little of it has changed in the time since the pandemic, and it was a major problem right up to that point. And we had to just make room for COVID talk and shoved it aside. But the opioid epidemic, one of the things that was fueling it was that you've got people becoming addicted to opioids and going to different doctors to get different prescriptions so they can't be tracked. Nobody knows how much they're taking.
Wait, the doctors don't, this is probably a dumb question, but the doctors don't have look through to their medical records. I guess you can stop that if you're a patient, right? You can say you can't see that.
Yeah, right. You can not transfer your medical records. Exactly.
Wow,
Your medical records don't follow you around like they do in Western European countries.
Huh.
So people basically would go to one doctor and say, "Hey, I've got knee pain," and the doctor would try to give them a non-opioid maybe toward the end of the this opioid scare, and they would say, "No, the only thing that works is OxyContin or whatever," and so the doctor would begrudgingly write them a prescription for that. Then a week later, they're going to go to their dentist and complain about tooth pain. And the dentist will check them out and say, "Well, you don't seem to have anything wrong." And they're like, "Well, just take my word for it. I've got pain in there. I don't know where it's coming from." And they'll grab another opioid prescription from that dentist and so forth. They just kind of keep this thing going. Anyway, that not to get off topic, but that is I think the sort of the story that you need to know to understand the healthcare system in the U.S. It's not connected. There's no connectedness whatsoever. So everyone's pretty much just doing their own thing, and which is actually part of the problem of part of the COVID response that I think most people agree did not go as planned, is because of that fragmentation. I mean, there's a lot of plenty people, plenty of blame to go around, but the fragmented aspect of the healthcare system fed into the opioid epidemic and then fed right into, pretty shitty COVID response.
It's also an issue just from a high level, very oversimplified view here, but it's an issue when you have competing interests in a way, even if it's not supposed to be set up that way, you have competing interests just between, say, the doctors and the insurance companies. Mm-hmm. Every doctor I know, everyone I know, they're always like, "Oh God, the insurance company." It's a common attitude, and I'm sure at the insurance companies, it's like, "Oh Jesus, here comes another doctor billing fucking $1 million for this kind of thing or whatever." But when you think about that, that's how people get the service for their health. So you literally have the two beacons of that never on the same page, and that has never made sense to me.
No, exactly. And it doesn't make sense to me either, and I've devoted my whole entire career to studying it. So insurance companies are providing a service that used to be just indemnity. So, they'd cover you for your losses, like it's a risk management problem, basically. And really, insurance was for big ticket stuff, right? It was supposed to be if something really bad happened, you're going to get some coverage.
Sure.
Then it's morphed over the years. It's morphed into this thing that is a little bit more intrusive into your life. Like the insurance company is going to tell you whether you can take a generic, a brand name drug or not. They might say no, you can only take the generic. But worse than that, I mean, that's probably one of the least objectionable things they do. Worse than that, they might tell you can't see, okay, you've got a new insurance company, you can no longer go to that doctor anymore that you've been going to for 8 years. That kind of thing. And the thing about that is, at the end of the day, that may not have a huge impact on your health. Having to switch doctors, you might find a new one, you might like the new one better. But at the end of the day, it's a pain in the ass, and it pisses people off, and it just and they're paying a lot of money for it. So if it's like I don't know, a service that you don't pay much for, right? There's a lot of things we get for free now. Well, like a lot of people will go online to get their news from the news outlets without subscribing. Mm-hmm. And they just see and then they max out on their downloadable articles every day, and then they're done. They're not going to subscribe. So, all right. So, we can sort of tolerate that, right? But with healthcare, in other words, there's only so mad you're going to get at that news organization because you're not giving them shit, right?
Sure.
But
it's not vital to you either.
Yeah, it's not vital to you. But your insurance company is like, now you're paying so much money, thousands of dollars a month for some people. And then all they seem to be doing is preventing you from getting the services that you need. Yeah. Not all of them. I mean, some of it depends on which plan you're in and blah, blah, blah. But at the end of the day, I mean, it is, it is, as you said, a contentious relationship between all three parts of that. The patient, the doctor, and the insurance company. They all hate each other. Nobody gets along in that equation. Because now we don't like our doctors because our doctors are doing all kinds of weird stuff that they didn't do before.
I love my doctors. I'm just throwing that out there. Love my guys.
Well, listen,
they've all been great.
I think the mics are hot. So and I'm sure your doctor listens to this. So
he does actually. I swear to God.
Yeah. Well, then I think besides Julian Dorey's
Dr. Christou, we love you, baby.
Shout out to Dr. Christou.
Yeah.
Besides that doctor, some people don't like their doctors. Some people are annoyed by their doctors. Some people feel disconnected from their doctors, and that the insurance companies are part of that problem. But also just that sort of general disconnectedness among pieces of the puzzle. Like, why doesn't, when I go to the doctor, it always seems like they're out of the loop on stuff. Why don't they know about the COVID test I got, 3 months ago? Like why do I have to be the one that keeps track of all this stuff?
One thing where I don't know if it's the word is defend doctors there, but maybe it's something that's wrong with the system is I've always been amazed at whether it's, say, a family doctor who just treats people of all different ages for all the regular stuff, or an orthopod, someone like that who's seeing a lot of patients a day.
Right.
How they keep track of that and how they do remember, oh, I saw this patient 2 months ago and this is what they said. Because sure, you have the notes, you go review it, you see how quickly and well and organized a lot of these doctors at least take those things. But there's still that disconnect of like, wait, did he say it felt like that or like this? Or I can't remember, was that a symptom or did I mean that when I wrote that? I'm always amazed at how some of the best ones are able to keep it straight because you're right. It is not a straight streamlined process at all, and it's not organized. It doesn't seem that way at least.
Well, and here, what is it, 2021 now?
Yeah.
And we're really like just getting into this electronic medical record thing. And I know that people are you're gonna get all kinds of hate mail saying it's been around for a while. It's true, it's been around for a while, but it's only in its infancy in terms of its full potential.
Yeah, I get my bill in the mail.
Yeah, I do. I still get bills in the mail. In fact, I tried to figure out a way to not get the bills in the mail, and they said, no, you can't do that. They're going to come in the mail. Oh, and then the best is, by the way, you don't have to pay any of them, because you need to wait until the insurance company settles out.
Yeah.
It's it's just like, all right, so what's the point of this whole thing? So I got to
call up to pay a bill and they're like, no, not yet.
Yeah.
We don't want your money.
Don't pay that. It's just going to confuse us if you pay that. And then you're not going to get your refund for a long time. So yeah, it's a messed up system. And these electronic medical records have a great potential, right? Because my electronic medical record should be in a cloud somewhere. And everywhere I go to the doctor, I either have a card with a chip in it that sort of allows them to access it, or I simply just have a password that I give them, or whatever. And then, like iCloud, right? It could be the same as that, right? I can access iCloud everywhere I go. My medical record should be in an iCloud, or some sort of cloud, and a doctor should be able to access it and see everything since going back to when I was 8 years old.
Right. And provided you give them permission to.
Well, of course. Say, hey, look, I've got a problem here. Have at it. Look at my record. See if there's anything in there that speaks to you. And the thing is that what doesn't happen now is that should happen before you get to the doctor's office, right? The doctor should prep for you. Yeah. Because remember, the doctor's like your consultant, right? You're not Dr. Christou. He's different. He's a family friend. Been through thick and thin with that guy.
He's loving the shout outs.
Yeah, and I think that's different.
He is a great doctor, though.
Yeah,
great doctor.
No, sure he is. I want to circle back to Dr. Christou in a bit. I want to find out more. Mainly, I want to find out what's the matter. You're seeing a doctor on a regular basis?
No, like that was just my doctor up in North Jersey because I had never lived there before. Oh. I'm like, oh shit, I need a doctor now. Who's the man? Oh. Like I could call him. What I really like about him is, I mean, you know me, we both went to Whippany together. So I had all the shoulder injuries and everything. And so I always think like something's wrong with a bone somewhere. So I'll call him up and I'll be like, hey, I got this thing. And he'll be like, all right, come in. Like a half hour later. Oh, that's awesome. I never had experienced that before because, I had an uncle who was a doctor down here. That was always my family doctor. So I was spoiled in that way. But I guess I had never really worried about that. And then you go to a new place and you're like, well, I guess I'm not going to get that because no one has that type of experience. And then someone you just meet, he does that. And it was just a really good guy. And whenever I would go in to see him, we'd spend 10, 15 minutes going over whatever it was. And then I'd talk with him for like 40 minutes.
Oh, that's nice. That's great. That's unusual. Yeah,
exactly.
Dr. Christie's special.
Exactly. Good.
Yeah,
guy.
that is good. And well, I think what's so interesting is why is that so unusual, right? You're talking about this experience, and I'm sitting here thinking I'm in the field, and I'm thinking this is really unusual.
Yeah,
it's really hard to find a doctor like that. I had some health issues in July. It may or may not have been COVID. I don't know. I kept testing negative, but I had a lot of I had like these like upper GI, pain and all that stuff. My primary care doctor, she stepped up to the plate. She's just like, I kept trying to call the office and everything, and she's just like, look, here's my cell phone, text me.
Oh, that's great.
And so as that disease or whatever it is, I don't know what I had, whatever happened there in that 2-week period, I was texting her all the time. She'd text back. And I think we solved a lot of problems just by texting. Whereas if I had to call her office, make an appointment, blah, blah, blah. But a lot of doctors won't do that. They do not want to get into that texting relationship with a patient. And I can understand why, right? I mean, there's a lot of reasons why that could go awry. But that's the thing, like that flexibility that she had. We just kind of slid into the texting, and we accomplished a lot that way. Just kind of sped things up. We got to cut through a lot of red tape and everything by doing that, and it ended fine, right? Everybody was happy at the end. But I can see how that's not going to work for a lot of doctors.
Yeah, I think a lot, and I could say this about other jobs too, especially what I did in the past. But a lot of the job of a really good doctor is being a psychologist. Which is literally that care, that personal touch, or actually pretending to give a shit and understanding that the patient's health is the most important thing in the world to them. So even if that's your 1 to 1:30 today, that's the most important half hour of their day.
Right.
And the people who get that and then can do some of the personal things like that, they probably develop actual relationships with their patients rather than just treating them as clients.
Right. Yeah, and but that has to be balanced again. So there's a cost to that, right? So your doctor talking to you for 40 minutes, that's awesome. And I think there's probably a lot of benefits to that. But there's also some cost to that. It's his time, and
sure.
Maybe there's a patient in the waiting room who would have liked to have gotten in there for those 40 minutes. It's finding that balance. Keeping medical care in the especially in this country has historically been that having that personal connection. And when you take that away, people start feeling uneasy about it, right? They get a little irritated. They start giving their doctors bad marks on the report cards that everyone's asked to fill out now. So doctors are aware of that too. So they're trying to balance that out. But there is this sort of efficiency that's crept into healthcare that I think most people would argue is a good thing, because healthcare, the whole other topic is just how wasteful healthcare is in terms of costs. The costs are just not like spent in the right places. Tremendous amount of waste, and it's probably better to focus on getting rid of that and making it more efficient. But at the same time, you don't want to throw the baby out with the bathwater. There's a lot about healthcare that is a personal thing. It's there's certain things in life that you don't want to depersonalize, and that's one of them, which I think is an interesting challenge for all these new developers, all the ones who are moving from Silicon Valley to Miami, who are developing apps, healthcare apps. I mean, and we actually, some of our clients are doing this now. So we did a project with a client. We did an economic analysis. They have an app that is it's like a PT, like a physical therapy app. Basically, you engage via the app to an actual person. There's a person who can come on every now and then and
like
chat
via chat.
Yeah.
Okay.
And maybe even more like a FaceTime thing.
Oh, they do FaceTime.
Yeah. I think it
That's
has
really
that
personal
capability. So there's a number of different ways in which the patient can interact with a person, but the main sort of structure of the app is around setting up workouts for you and demonstrating to you those workouts for specific PT problems. And you do them at home. And you turn the app on your iPad, so you have a big enough, or your laptop or whatever, so you have a big enough picture, and you go through these routines, and they tell you very patiently what to do.
Was this invented for COVID specifically?
No.
This is before.
Yeah, this has been in the works for years, and I won't say that they were thrilled that COVID came along, but obviously they were like, I told you so, basically saying, here, see, look, I mean, now these people can work on their PT stuff at home. So you could say, well, there's all these, like you could go on YouTube and find all kinds of exercise videos.
Sure,
right?
It's not personalized though.
Yeah, it's not personalized. And you don't, and there's always that thing like, well, I don't know if this is really the right thing for me. This thing supposedly, this app sort of gets around that by saying this is the, given everything we've learned via all the stuff you've put in there, we think this is the right way for you to go about your physical therapy. And it's taken off. I mean, as far as I know, it's hugely popular now. And one of the things that we did was we basically showed that it's a cheaper way of delivering PT. Obviously, but not just because it's cheaper to do stuff via app. It's not just that.
What type of client was it though? Was it an actual physical therapist? That's where I'm a little confused.
The client. What do you mean by client? You mean the
who you did the analysis for?
Well, it was the company that developed the app.
So they just specifically did that. So they obviously on their end have physical therapist professionals. Yeah. Whereas it wasn't, say, JAG Physical Therapy coming out and saying, oh, we offer this now.
No. But
right.
I mean, I'm sure there are. I'm sure those guys exist, the more entrepreneurial physical therapists. But no, this is a company that got venture capital and everything and developed this app. And what else was I going to say about it? I mean, I would say that like the thing about it is it's not just the app is not where the savings occur. In other words, like, doing it at home instead of in an office and stuff. Obviously there are some savings there, but it's the access thing. It makes it so that more people can get care. It's more accessible, maybe not to people like my mom, who still is a little bit challenged, with apps, but to most people within that, the big users of physical therapy are like people between the ages of 25 and 45, because they're involved in stuff like you were saying, you hurt your shoulder. Like
been in there a few times.
The boxing gym is a major source of physical therapy referrals.
Yeah,
so
been a regular.
Yeah. So that's the sort of the sweet spot for a company like that. So therefore. Their main goal was to connect with employers, because a lot of employers in the U.S. offer employer-based health insurance, and so they could go to.
Wow! So this app is literally working in the sense that they bill through health insurance just like a regular physical therapist would. And, oh wow!
Yeah, exactly.
Wow.
So the reimbursement, like it's all coded already. So
sure,
PT visit of a certain kind gets reimbursed a certain amount.
So they need scripts and everything just like normal.
Yeah. And if they need scripts, they're going to get it probably from, I'm not sure they can get scripts through this apparatus. I'm not sure if that, they might have to go to a regular doctor for that. But all the movement stuff that a PT does, I believe was baked into this app. And again, it just increases access. So what you have is the ability for some person who is going to have either trouble getting to a PT office or just simply trouble getting to a PT office because it's too far, or because they're too busy, or they have little kids, or like there's 10 different reasons why it's a pain in the ass to go to a PT office or any doctor's office for that matter. So that the app sort of brings the thing home to you and makes it more accessible, so you're more likely to do it.
It's a time saver. It's convenient. It's like every technological innovation ever. I mean, I used to think about that. Especially because I did at least 2 full shoulder rehabs post-surgery. And so those were each 5-month periods, going to the physical therapist for, most of it was 3 days a week. And then by the end, maybe it's like two days a week, something like that. I used to think about that, man, going here, had to drive there to go, right? So 20 minutes across town to do it. And then changing, getting in there for an hour, getting stretched out for a half hour, leaving there for another 20. I mean, it kills 2 hours of your day. And then you think about the people who have jobs, have families, responsibilities, and suddenly, they have to get surgery on something, and now they have some hardcore rehab for 6 months. I mean, that's 6, 8, 10 hours out of your week every week for 6 months, and you're paying for it too. I mean, it's really a crazy thing when you think about it.
Yeah, it is. And that's actually a really important thing about healthcare is that the time that the patients invest in their care. And if you can cut back on that, then there's some efficiencies there. And that was sort of a forgotten thing for a long time. There wasn't a lot of attention paid to that. People, the assumption was that people would just, invest infinitely in their time and, take days off from work and all this stuff. And now it's just, that's changed for a whole lot of reasons that people are just much more conscious of their time. And
COVID too, because, it's like you're already home, you're forced to be home, and you couldn't go to places for a while, so people had to learn to be remote. So now they're like, oh, well, I can do this remote too. I mean, there's so many jobs in this country. At my old job, I used to tell these ladies I worked with every day, they went in there for, Christ, they were there for like 30 years, one of them. And I used to say, Diane was her name. I'm like, you realize you could do this entire job at home. And she'd be like, you're crazy. You're nuts. I could never do that. And I'm like, Diane, the only reason you don't do that is because the bank doesn't let you do it. I'm like, you could totally do it. So when they went to shut down the office of COVID, she was flipping out. She's like, what am I going to do? 3 days in, she's like, oh my God, this is the best thing ever. So people, then they started to look at the rest of their life too, where they were already forced to do it. And they're like, okay, well, I'll do that remote as well and that remote as well. And now it's like a new norm.
Yeah, it's amazing how companies, sort of woke up to the fact that, I guess nobody had to come into the office to do this stuff.
Yeah,
and I think that's a really interesting phenomenon. And it does these sort of home-based. Our mutual friend King Kong Fitness. He's he's pushing a lot of business online now. Shout out to King Kong Fitness.
He's actually great at it though,
yeah,
because
of course.
Even through a camera, that dude's screaming in your face.
He's
after
up in
you're like, let's go, baby, go on.
He's right up in your grill, and I'm sure he can do that through any sort of mode of communication.
I've seen it.
Yeah, and so guys like that are killing it online now, and of course the COVID. But so again, just like the work from home thing, the COVID's making people realize I don't need to go to the gym to see a trainer. Or I don't need to go to the gym just to work out. I'm going to do it. I'm going to buy some equipment. I'm going to move to a bigger house or a bigger apartment. I'm going to get some equipment. I'm going to cut my gym expense.
Some people are doing that. You're right.
Yeah.
I can't relate to those people. I miss the gym like crazy.
I agree. I'm the same way as you. I was dying to get back in there.
Ugh.
And
how is it up there, by the way? How are you doing?
It's good. It's good. In fact, I don't usually go in on Saturday. And the nice thing about Saturday at the gym is it's a slightly more relaxed atmosphere. And I got a great workout with Ray, EPS training.
Shout out Ray.
Yeah, at Goat. EPS training. He's a fantastic trainer. And he just said, hey, I'm doing legs today. Tag along. We'll do legs together. So he and I worked out together. But then a bunch of, some of the old boxers were in there. And
are they masked up when they're boxing? I'm like afraid to ask this.
Yeah, no, I mean, for the most part, yeah. I mean, I think there's the pulling down the chin guard effect with the masks after a while.
I love all the NBA coaches, like on TV, they're wearing a mask, then they bark out in order. I'm like, COVID ignored the last 30 seconds, I guess.
Yeah, well, I mean, that's the thing about the COVID restrictions is that like the closing of the bars, like in New Jersey, like you can't sit at a bar, but you can sit in the same room as the bar. And so it's like, wow, this COVID virus is a crafty son of a bitch. The COVID virus lays in wait for people to sit at the bar. But if you're back on a high top, 8 feet away,
it won't come back there. It knows.
You were good.
It knows. There's the please wait to be seated sign.
Yeah.
So COVID knows. Yeah. Got to wait for the maitre d'.
And also COVID knows that a great place to prey on people is when they're going to the bathroom.
Yeah.
So we have outsmarted them, those viruses, by wearing masks when we go to the bathroom. So we're totally protected.
Yeah. Regardless of the biology there, which there's plenty, or science, however you want to say it, there's plenty of science to back the whole that this is an airborne virus. We know that at this point, and so masks certainly seem to help.
Right.
There is only so much you can do with an airborne virus, and it's interesting, obviously, the route Florida took here, just because, yeah, you have a lot of people who are doing everything they're supposed to do in other states where they're wearing their mask and wearing it out, wearing it in, but they're still getting it at home because they dropped their guard for 1 second. You know, they take it off for 1 second. No one is going to wear the mask into their bed at night and sleep with it on and wake up with it still on.
Right.
And so it's almost like it's an unfortunate thing, but I feel like at this point we're asking people to do something that really is technically not possible for the fact that you need 100%. You need 100% mandated following of it, not just by people doing it, but by people doing it 100% of the time.
Right. Right. And I think I agree with you. The mask it's better for people to wear masks than to not. And I think that we can, I think the science on that is pretty strong right now. But you're right. I mean, I've always said right from the beginning, and you know, I think probably what you were getting at before when you were asking me what I do. I mean, we got thrust into this in our company, not just because we had some clients who wanted us to do some work related to this, but simply because we have a lot of clients who are in the space, in the healthcare space, and they just wanted information, and they wanted to engage with us on it. You know, I had former clients and just friends and colleagues and everything just calling and wanting to talk about COVID, because you know we being in the healthcare space had to sort of bone up on everything really quickly.
Now, what kind of work specifically? Because you walk through, you do the economic planning, stuff like that, and you walk through what that was. So when it pertains to COVID, can you give an example of, besides a client just calling you and asking your opinion because you're in the space, but when you're actually doing a project for someone, what that might have consisted of? Yeah.
So we have a client right now, for example, who's developed a differentiator, a diagnostic that differentiates between bacterial and viral infections. So it's an infectious disease diagnostic. And they look at that and they say, well, we should be, and it's a rapid test. So in other words, gets results back, you know, almost immediately.
That's an interesting space right now too.
Yeah, it is. That's a rapidly growing space.
Yeah.
It is. So back to this test. So what this test does is tell you whether somebody's got a bacterial or a viral infection. So,
and what's the difference between the two?
Good question. So a bacterial infection, it's really only in the treatment. So a bacterial and viral infection can appear to be the same in a person. It can be very difficult to differentiate by looking at them. So they can both give you a fever, they can both give you a rash, they can both make you feel like shit. And interestingly, one is not necessarily more dangerous than the other. I think generally bacterial infections are more dangerous, but some viral infections can be very dangerous too, as we've seen with COVID. But a bacterial, so when you want to know whether when somebody comes into let's just think about the ER for a minute. There's a lot of different settings in the healthcare industry, but let's just think about the ER.
Sure. Somebody
comes in, and you're the first doctor to see them, or maybe you're a nurse practitioner or whatever, and you suspect infection. They've got, they're sweating, they're feverish. So some type of infection. Could be viral, could be bacterial, could be COVID nowadays, or it could be something else. So what you want to do is rule out life-threatening things. And one life-threatening thing is sepsis. That's a deep systemic infection in your body, bacterial infection in your body. And if you have sepsis, or you're at risk for sepsis, so patients can get into sepsis very quickly. If you're in that situation, that's a life-threatening situation, needs immediate treatment with intravenous antibiotics. So we want to know right away whether somebody's got a bacterial infection. Now, we've had some clients in the past, and there are some companies out there that have developed tests that don't just have two readouts, bacterial or viral. They might have a third readout, which is mortality risk. And that tells you sort of how bad is this infection. And that can be based on just the way your body's reacting. It's called like a host response. So if your body's reacting a certain way, big time, then your infection's probably worse. And if that infection's bacterial, then okay, we got to really move fast here. So we've had a number of clients over the years that develop tests like that. And now a lot of these clients are saying we should be in the sort of COVID chain of diagnostics. And we should be not just in there, but we should be first. So when somebody presents in the ER, let's find out right away, not whether they have COVID or not. So right now, what's happening for the most part is patients are coming in. If they're suspected COVID, usually there's a screening or something at the ER. They say, if you have a cough and a fever and all that, and they'll take your temperature. And if you look like you've got COVID, they're going to do a COVID test. Well, what these guys argue is that you should do a viral bacterial test first. And if it's bacterial, COVID's viral, right? So if it's bacterial, we know it's not a COVID issue. So then we move them over into a different stream. We triage them out into a different stream, a non-COVID stream. And then we check to see, is that a bacterial infection that could be sepsis? Or is it because, they've got a wound that hasn't healed very well and they've got this host response going on showing that they've got an infection.
And they're not just adding a step to the process there?
Well, they are adding a step.
Okay.
But the manufacturers argue, and a lot of doctors too, that that's an important step to add because you're helping the healthcare system
streamlining.
Yeah, it's a triage, right? So you're getting people to where they should go, and that was one of the biggest problems with COVID when it first broke, and it was a horrifying experience for hospitals because they're like, what the fuck are we going to do when these people start showing up? Because a lot of them, what they did was they set up triage out in the parking lot.
Oh, do you remember Morristown Medical at the beginning?
They did that, right?
It looked like an army base in the back.
Yeah, like a MASH unit.
And part of it was luck of the draw, or I don't know if that's really the way to say it, but one of my clients from my previous job is, don't want to give away where he is, but he's in a very prominent position in a South Jersey hospital. Mm-hmm. So South Jersey did not get hit like North Jersey.
Right.
At all. North Jersey was basically in the eye of the storm. And what he was explaining to me a few months later was that basically all the hospitals in South Jersey, just by the spread of how COVID happened, because it didn't come to Philly when it came to New York at the same time, they ended up getting an extra week. He said we were all working together beginning that last week of February. Every hospital, literally, who was like a name around New Jersey, was on the phone with each other, on meetings, figuring it all out. And he said, we basically got an extra 6 to 7 days, and that made all the difference. Because, like you said, it was just, they were blocking it. It was zone coverage. There wasn't even blocking and tackling. It was crazy.
Yeah, and nobody knew what to do. That was the interesting thing about this virus, and we can get into this because the whole response is nobody knew what the fuck to do.
Well, actually, I need to give you credit here too. You called this. I talked to you on the phone. This had to be like mid-February, maybe, maybe that last week of February when the market was first tanking. But I talked to you on the phone, and you were explaining to me, and I'm gonna forget some of the details, but you're just like, our system is not set up to be able to deal with something that it's never seen before. Those, I believe, were your exact words. And you're like, especially right now, it's just completely unorganized or disorganized down in Washington D.C., and this is gonna be a clusterfuck. And it was.
Yeah. Well, yeah, and I think it goes back to this fragmentation that I was talking about, but also, obviously we also had this unique situation, hopefully unique, where we had this just giant leadership void. Yeah. We have politicians who just were not up to stepping up to the plate in the sort of traditional way that a leader might step up to the plate. If you've been in corporate America, if you're a CEO of a big corporation, and your corporation's facing some sort of adversity of some kind, the most common would be like a catastrophic recession or depression or something like that. You're responsible for figuring out a response immediately, and it's going to be your ass if you don't. Yep. And you have to step up to the plate. You have to put aside. Now, would you rather, if you're the CEO of a Fortune 100 company, would you rather just go to an island and hang out on your yacht? Yeah, obviously, right? But you can't do that because you're a leader of an organization and there's people depending on you to be an adult and step up to the plate and make the tough decisions. And that's all the leadership at the corporate level in this country is sort of expected to do that. And if you don't, the board's going to get rid of you in a heartbeat. They don't have the time for that. They don't have the energy for that. They don't want the stock to tank because of you. And so they're watching you and they're holding your feet to the fire, and you've got to behave. You've got to step up to the plate. You got to buck up, and you got to man up, and you got to do what's right. And that's the way corporate America works. That's why we have some of the best corporations in the world here. That's not what happens with elected leaders.
Yeah.
Our elected leaders don't have necessarily the skills required to lead the country. That's because that's not a requirement. You just need votes. You don't need skills. They don't have the emotional intelligence. They don't have the emotional maturity. And so, when they get to now, that doesn't, I'm not talking about, Anthony Fauci at the CDC. That guy's got a great resume. He's 100% qualified. But the problem with Fauci, it's not with Fauci, but the problem with the system is that guys like Fauci, they can't actually do anything.
Yeah.
They don't really have a lot of power to actually do anything implementation wise. So
they become political footballs too.
Yeah. So so the CDC can produce a lot of documents and data and experts, and they can all get out and they can all talk about what's going on. And there are certain things they can do from a public health point of view, but by and large, they don't have a lot of power.
Yeah.
So it really comes down to leadership. And what we saw with COVID was we saw some good local leadership in some parts of the country. And when I say good, we could talk about what's good and what's not good.
Yeah.
We started out talking about shutdowns, right? So is shutdown good or not? Just table that for a second.
And it's also at the beginning, it's kind of a little bit of a different context.
Right. Exactly. That's a good point. Because at the beginning, we didn't know whether this thing was just going to kill millions of people. And
prevent defense.
Prevent defense. Everybody fade back and just prevent this thing from getting out of control until we can figure out what the hell's going on. Yeah. And that's what we had to do, right? And so that was a critical time. And during that time, you had some people in Washington literally calling it a hoax, not taking it seriously, downplaying it. But then you had other people in Washington who were trying to do the opposite, trying to sound the alarms. And then you had a lot of local leaders who were like, okay, they can do what they can say and do what they want in DC, but at the end of the day, I've got to figure out how to keep the people in my community safe. And so this is a really interesting problem.
Yeah.
This is not a problem that America or any country faces on a regular basis. So we had to figure out really quickly how to coordinate all that shit. And I think at the end of the day, we still haven't figured that out. We still have this disconnect between local leaders who are trying to do one thing, and not just local leaders, but you also have joining that local leader, let's say a local leader is a mayor or something like that.
Yeah.
Joining that local leader is the CEO of the hospital, not just the CEO of the hospital, but the medical director at the hospital. And you got to bring them to the table too.
And then above them, and then above them, and then above them, there's layers and levels.
Layers and layers. Everybody's got to get their shit together.
Yeah.
And it takes a tremendous amount of, I would say, it's not just emotional intelligence, it's emotional maturity. It's like everybody just needs to just bring their A game, and just figure out what to do. Like if people who can help, bring them in. And that one thing that didn't happen that I've always thought, I had a friend in college and he and I always used to joke around about what we would do if we were president. And I was an economics major, and he would say, "Oh, I know if I'm ever president, I want you to be my head of treasury or whatever, or my chief economic advisor." I'm like, "Oh, that's nice, thank you. I don't know shit." But the reality is that's exactly what we needed. We needed someone to say, "Okay, we need to marshal together." Like, think about it. The U.S. has the best universities in the world. I mean, there's a lot of good ones in other countries, but the U.S. has the highest concentration of ridiculously high-ranked and high-powered universities.
That's right.
And what I'm talking about mainly is the graduate side of the university, not so much the undergrad, but the professors who are engaged in research. Like Johns Hopkins has some of the best infectious disease people on the planet, and they're all there.
Yep.
And they also happen to be 45 minutes outside of DC.
Yep.
If that.
Yep.
They're right there. They should have been brought in along with, a bunch of others from around the country, and they should have had right away a big meeting of those experts. And they went, and I guarantee you, I mean, it's always hard, right? You've been to these things, the conferences and stuff like that.
Yeah.
When you get a bunch of experts together and they don't agree on anything.
Yeah.
That happens, right?
Yeah.
So it's not a panacea, right? This isn't going to be the guaranteed, sort of solution to the problem. And I'm not doing this sort of retrospective or ex post rationalization. Like I think there would have been problems with that too.
Yeah.
But the fact is, it didn't happen.
Yeah.
Think about it. That didn't happen. This is the biggest public health threat that this country's ever faced. And we didn't call an emergency meeting of all of our infectious disease experts. Fauci's there. He's a infectious disease expert at the CDC. He's involved. Great. We should have had 20 other people in there. And
might have put more trust in it too, because he really, in the public eye, and again, like became a political football. But I got so sick and tired of that guy because he changed his opinion every goddamn week.
Yeah,
and then just you point out this really interesting, I guess you could call it a dichotomy that happened here. But yeah, you had the extremes form right away.
Mm-hmm.
There wasn't really people saying, okay, we know this is real. Here's what the data says. This is a lot worse than the regular flu.
Right.
Haven't really faced something like this before.
Right.
Here's what we can expect. Here's what we got to do to put the pieces in place to try to get a response going. Like, you didn't have the people saying that. You either had people saying, we are all going to die, or, oh my God, go outside, like, relax.
Yeah, exactly. And that's not what we needed, right? We didn't need the extremes. We needed that middle, that sort of educated middle. And we had it. We have all the people here who know about this stuff. And if you're concerned about the economy, bring some economists into there too, and let them weigh in. Like, we really needs to be a groupthink. And I don't even care if half the room's economists and Chamber of Commerce people and half the room's scientists. That's okay.
That would be a beautiful thing, because you would mix the medicine and the business. I mean, we didn't have that.
Yeah, and by the way, those things are related. So if we just put everyone out, and this annoyed me about my people in public health, the extreme sort of people in public health who want to just shut everything down indefinitely. It's like, you know what? That's going to cause a whole host of healthcare problems related to people being out of work and depressed. And no money, and the economy being plunged into a recession. That's not good either. Yeah. We don't want that either. Got to strike a balance. But given that we've never faced this before, and given how complicated it is, the virology around COVID, very complicated, the interaction of a lockdown and a lot of sick people with the economy, also very complex.
Yeah.
We need the best minds thinking about this, and we need a leader. Leader doesn't have to know shit. The leader just has to know how to get the best and the most out of all those people and put it together in a coherent fashion. And so the leader can get what they can out of the experts, then go back, talk to their advisors, and talk to Congress, talk to Senate, and figure something out. And have it be one of the things we lacked at that time. Was a consistent message. So you just alluded to this. You said Fauci annoyed you because we heard different things. Ugh. It's true. And
all of them.
It was a problem. I mean, every single one of these, anyone in front of a camera kept saying something different. And if they weren't saying something different, it was Cuomo saying, we're all going to die. And
we're all going to die.
Yeah.
Hey, I have you know how many people we have working back here? Do you know how many people? What, you have to stay in your house. We have to flatten the curtain.
Yeah, exactly. So listen, I think the history books are going to be kind to him when it comes to COVID, but at the end of the day, how helpful is it to just sound the alarm to that extent and shut everything down and have her? I mean, I'm sure he prevented a lot of cases that could have happened in New York and a lot of deaths that could have happened in New York. I have no doubt about that. But
yeah, what was with the nursing home thing though?
Yeah,
I mean, because he drove, and that's the thing. I disagree with you in the sense that I don't think anyone's going to have a good looking record. Honestly, the guy who's going to have the best chance, if I were betting right now, to have okay record, depending on who was looking at it, is DeSantis. And the people who don't like him when they look at him are going to hate him for it.
Yeah.
You know? So even that, it's drawn along political lines. But this is actually another little leadership point within here that I wanted to ask you about, which is you had an enormous fragmentation with who's calling the shots. Mm-hmm. So yeah, you have, I guess the president is the main leader of the country, of course, but states are making decisions on their own.
Right.
And then I guess the governor's at the top of the chain, but you even saw, for example, Cuomo and de Blasio disagreeing on stuff. At least they told us that publicly or whatever.
Right.
And so you had all these different places. This is a big country. A lot of different places, different priorities, different personalities, different politics. And it's like, okay, well, this guy's saying that chick's saying that none of that's the same. And now everyone's going to yell at each other because, by the way, everyone's home, so they got time to go on the internet and yell at each other about it. So I guess my theory is that in a lot of ways this was doomed to fail because we had that fragmented system where the states and the federal government can operate on a different wavelength. And I'm a huge supporter of states doing that. And you run into slippery slopes with scenarios like this because you say, well, I guess we can't do that again. And now you give the federal government all control, which is not how this country's set up. Right. But I kind of wonder if there had been one response to it and then everyone had to work on the same team because that's what it was going to be, and then just lobby their way to get their ideas in there the best they could. Maybe it could have been a better response. But what do you think?
Well, yeah, I think that, well, that's it's difficult to answer that question because
it's loaded.
Yeah, there's a lot there. But look at it this way. So you could, from a leadership position. So I think what you were getting at is this federalism thing. The United States is set up so that states can do what they want, right? I mean, that's the whole backbone of this country. I mean, most people think of it as the Constitution. Yeah, that's pretty freaking important. But the next biggest thing in this country after the Constitution is states' rights. Yeah. And the ability of states to but what happens when you have, well, this has happened during, I haven't been alive except for I was born during the Vietnam War, but essentially, not counting the Gulf War and Afghanistan, I wasn't really alive during like a big wartime effort. So I don't know what that's like.
Where there's a draft and all that,
Yeah, and we're like everybody, my parents knew about it. My dad used to tell me stories about World War II.
Oh, sorry about your dad.
Oh, yeah, thank you. I appreciate that. Yeah, so he'd tell stories about what it was like to be a kid. He was just a kid during World War II. And he'd say, he'd talk about how unified the country was around that effort. And so, like, for example, in World War II, there were a lot of little things going on, like like metal was very scarce. So like your board over here is going to be, and all the electronics that you have over here would have been, like somebody would have said, no, you're not going to get that for your podcast. We need it for the military effort. And you would have been cool. That's great.
Oiled metals, like steaks and meats and stuff. I mean, it was
food. I mean, if so much stuff was just allocated to the military, and everybody's completely okay with that. And turning out your lights along the coast, right?
I didn't know about that one.
Yeah, the Jersey Shore. My mother tells me this story that because she had some relatives who lived down the shore during World War II.
U-boats and stuff.
They all had to turn out their lights by a certain time at night so that the U-boats couldn't see where the coast was, because they didn't have, the sonar. Sonar nowadays kind of can look in any direction, but back then sonar was sort of kind of clunky and only looked in certain directions and only for so far. Yeah. They had no radar. So if you're a U-boat, it's snorkel up to see how close you are to the coast. And if there's lights, they backlit a ship, then you could fire at that ship being backlit by the lights on the land. God. So the country basically just said, please turn out your lights by a certain time. It's to prevent our ships from getting fired on by U-boats.
Did they mandate it?
Well, I don't know.
Because they mandated a lot of the rations.
Yeah.
They mandated that.
Yeah, they may have mandated it, but think about how hard that would be to enforce, right?
Yeah.
Because you don't have, remember the police force is decimated too because they're all out fighting. Yeah. So imagine how difficult it would be to enforce that. But people did it. because everybody thought, okay, I got to do my part in this cause, right? And again, we're speaking on this. You and I are too young to actually have been involved in that shit.
Such an interesting time, though.
But it must have been a very interesting time, right? Because the country rallying together. So even with states' rights, in wartime, states have to coordinate, right? Yeah, we got states' rights, but what if California decides to put their lights on? Then we got a problem, right? So I think at some point there are certain things that a country is faced with where everyone needs to rally together and work together. And I think this was probably one of them. And of course we blew it. And to those who are still alive, who were, survived up until now and lived through wars like World War II, some part of them, and actually my mother is one of them, I think, is disgusted by the way things happen, by the way everything played out. Just disgusted. She doesn't understand how this could have happened, right? In this country, which her parents actually fled from Germany to come here for a better life because they didn't,
when?
In the late 20s.
Yeah, they were burning Deutschmarks for fire back then.
Yeah, exactly. Yeah, wheelbarrows full of it.
Yeah.
So they fled that and came here looking for a better life. And I think for people like my mother, I think they think, what the fuck happened to our country? And we're a bunch of bozos. She's disgusted by everything that's happened in the past, not just the pandemic, but the whole past 4 years, about where we're at as a country. Yeah. But just sticking to the pandemic, I think we had an opportunity to work together and to invent a way to work together. So maintaining states' rights, people's rights. I agree with you about DeSantis. I think DeSantis is going, because what's going to happen with DeSantis, governor of Florida. He's going to have his
haters, though. He's going to have, what I mean?
He already does. I mean, he's got some serious haters.
He's not going to lose those.
But for the listeners, Ron DeSantis is the governor of Florida, and he is been a very pro, let's keep things open kind of guy. And I think, you and I have talked about this before. What are the repercussions of opening things up during a pandemic versus shutting things down during a pandemic? And I think, surprisingly, if you would ask me that when we had that conversation in February, of course, that was before all the shit went down.
Yeah, it was like literally 2.5 weeks
right
before
on the cusp
the shutdown.
On the cusp of it. If we knew what was, I would never have guessed. That was a year ago almost, right? That we had that convo. If you told me a year from now we're still going to be dealing with this shit, I would have said, nah, that's not. See, I would have prognosticated in the wrong direction. Yeah. I would have gotten one thing right and one thing wrong.
I don't think anyone would have said.
I would have said, no way. We'll be completely over it by then. In fact, at that time, I was telling, again, when you're in this field, everyone's always asking you what's going to happen. And I was telling people it's going to be over by July. I was saying that in March.
So you at least, because, there weren't a ton of people going that far out. I mean, I remember at the beginning of this talking to people like, so if we stay inside for 2 weeks, that's the maximum incubation period. Then the government will say, all right, 2 more just to be sure, and we'll be good. Yeah. We'll be good.
And that was not an unreasonable stance. No. You know what I mean? Like, you're a smart guy. I think a lot of people thought that. And I don't know, I was saying July because I was thinking about the weather, and maybe once that warm weather comes to most of the country, it's going to kill it off. The virus isn't going to like that warm weather. Cold and flu season's usually when it's cold. So I was thinking we'd get in the clear in the summer. And I think the, back to the DeSantis things, I think, back then I think people thought, well, let's lock down and let's do it. And, I think some people had fun with it, right? I mean, let's be honest. Some people thought initially it was kind of fun to watch how people were dealing with lockdown. And there was a lot of reaching out. I heard from all kinds of people I hadn't heard from.
There was a lot of that at the beginning.
A lot of reaching out, and that's kind of fun a little bit. I mean, some people from Facebook you don't want to hear from, but
it's like a long sleepover.
Yeah, it was like a long sleepover. But you're not
necessarily. Some of you are together because you quarantine together, but you're not necessarily together. But it's like, oh, we're working, but we're not really working. We're on Zoom.
Yeah. I remember all those unnecessary initial Zoom calls. Like, everyone wanted to do a Zoom call. Yeah. Like, people who you rarely have any contact with were like, we need to do a Zoom call. Why? We never talked. We didn't talk before the pandemic. Now,
I didn't fucking like you then. I don't like you now.
All of a sudden, we gotta get on the phone, or get on the TV screen. So there's a lot of that stuff going on at that time. Nobody really thought, that any of this would happen. So again, back to Ron DeSantis, he stayed on message saying, no, we're just gonna stay open. And the problem, though, that I think maybe where we disagree on how DeSantis will be remembered, I don't think DeSantis came into it after doing a shit ton of research.
Oh, no.
He basically he literally rolled the dice. And Florida, he's got a lot of old people.
He was also late, too, at the beginning.
Yeah.
Like, he didn't end of March, people were just like on the beach, and that obviously we now know was mostly fine, but people were in the restaurants and everything, and just there was nothing.
Very late. In fact, he only did stuff about the beaches because, actually, again, back to this fragmentation thing, the mayor, there's a Miami mayor, and then there's a Miami-Dade County mayor.
Which one's Suarez? Miami?
Suarez, I don't know. I always forget.
Yeah. He's the guy, though. Suarez is the kingmaker right now. He's the guy.
Yeah.
Sorry, go ahead.
Yeah, he's. Actually, I don't remember which one he is, but anyway, those guys had stricter restrictions because that, obviously the biggest, most densely populated city in the state. But
not Fort Lickerdale though. You ever see that map at the beginning?
Yes.
My God. Because I guess that's where they got the people on video saying, if I get corona, I get corona.
Yeah.
And you just see all these like beep, all these lights flying out around the world. I'm like, oh man.
Yeah. It was interesting. So there was a joke actually toward the beginning of, not a particularly funny joke, but it was toward the beginning of the pandemic. People were joking that Boris Johnson in that's his name, right? But in the UK, Prime Minister, that he was saying, the joke was that he said that the UK was volunteering to be the control group. In other words, like, we're just not going to do anything and see what happens.
Yeah.
Because he was slow as well to get on it. Certainly by European country standards, he was very slow. And I think, that joke, I think, is actually kind of like there's some, I kind of like that joke because being somebody who is involved in clinical trials and stuff like that, where there's a control group and an intervention group, I kind of understand the value of it.
Sure.
You kind of need to see, it's going to be really helpful at the end of the day that we have some states like Alabama and Florida that didn't do jack shit. And then we have states like New Jersey and New York that did a lot.
It'd be countries like Sweden too.
Yeah. And then the countries, Sweden and
Belarus.
Belarus. And so we have these like natural experiments, which, the researcher in me loves the natural experiment. I hate the fact that people had to die, but the fact that there's a natural experiment where you've got, here's one way to react, DeSantis. Here's another way, Cuomo. Well, let's see what happens, because we're not. It's interesting. Like, no institutional review board would agree to a study where you randomized COVID patients to not COVID patients, individuals at risk for COVID, to a state that had no rules versus a state. Nobody would.
It's a lawsuit waiting to happen.
It's a lawsuit waiting to happen. You absolutely would never get that study approved, because it would mean you can't get a study approved if in one of the arms there's going to be more deaths.
Yep.
And that a priori, that's not going to get approved. So, but at the end of the day, that's what we have.
Because it was a normal emotional and I guess some logic, just whatever you call logic, reaction on different ideas to how they were going to handle this thing that was like, oh, well, this is here now.
Yeah.
It wasn't so much this long premeditated, we're going to figure out this country. All right, you guys aren't going to shut down. You're going to shut. It wasn't like that.
No, not like that at all. So we have this, we have the natural experiment with countries, but the problem with that is, and this is all like, we're all, any international comparisons of anything that includes Sweden don't really work.
Why is that?
Because Sweden is so different than the U.S. Okay. Like, first of all, they're all the same race.
They're spread out.
They're more spread out. Their cities are, a lot calmer and sort of like not as congested as ours. And if you've been to Sweden, also everyone looks the same. So I think there's a lot of stuff about our country, the diversity in this country, that make it different. It doesn't. I'm not saying one way or the other. I'm not saying we're worse because we're more diverse, or I'm just saying it's very homogeneous in Sweden. So when Sweden does something, like
scientifically, it's not worth as much to you.
Right.
Yeah.
Because that's a group of people. That's a very controlled society. Not in a the China kind of way. I don't mean it that way.
Yeah.
I mean it's controlled in the sense that you don't have a lot of noise. Everybody makes the same amount of money. Everybody looks the same. Everybody, dresses the same. Like it's a very homogeneous culture. And I'm not saying this. I know this. I've got some Swedish friends. I'm going to get some hate mail on this, but to me, that country is not a good comparator to the U.S.
And let me ask you on this though, because this is something we hear a lot about in headlines, and I've read some stories about it, but I'm not going to pretend to understand. There, especially when you're dealing with viruses, but really with anything, I guess, and correct me if I'm wrong, any type of disease, there are enormous differences in how it can affect people of different biological races.
Right.
So with COVID, what's been the experience there besides and this really has nothing to do with race other than it has to do with types of communities, but people have been saying there was a higher impact on Latinos and Black communities, especially in urban areas, and a lot of the connotation there was because there are a lot more people concentrated in those areas and not so much the virus itself. But besides that, the actual virus itself and the science, like how much is that true and how does it affect different people?
Yeah, good question. So, and these data came out from China initially because China had to deal with
That's terrifying.
Yeah, so we initially got data, but published by Chinese scientists in peer-reviewed journals, the same journals that we publish in. So there's a little, it's a little better than anything coming out of the government. That said, a lot of the data that they're using is coming from the government.
Yeah.
So, but even in those studies, we did see. Now, what's the problem? It's the same thing we were just talking about with China. There are, besides, there's always exceptions to the rule, but there's very few obese people in China.
Yeah.
Now, but there is a lot of hypertension in China because they, just for some reason they seem to be susceptible to that, but much less diabetes. I was going to say obesity, but diabetes and obesity, much less in China than in the U.S. Sweden, much less obesity.
Yeah, like none.
Much less diabetes than the U.S. U.S. has a crap ton now of obesity and diabetes. It's out of control, and those two are related. So these metabolic disorders in the U.S. are just off the charts. If we could show the audience a chart, it would just look like that. Like it's
I'll pull that up. I'll put it on.
Obesity and diabetes are just out of control in this country. So to your question, so COVID seems to attack people with those metabolic disorders much worse than it does with people without those metabolic disorders. So, and not just metabolic disorders, also seems to be a hypertension connection. COPD, which is chronic obstructive pulmonary disease. If you've got that, you're going to be more susceptible. Asthma is something that's more common in the U.S. than a lot of other countries, a lot more common. So you go down the list of all these sort of health plague that the U.S. has been a leader in. We're out in front of pretty much all other countries. The only country that got out in front of us on obesity was Germany. And
really?
Germany started having an obesity problem before we did. But I think we've surpassed them now. I'm not sure of the data, but I think we have more obese people.
Yeah, this sounds more like a country thing rather than an ethnicity thing, though.
Oh yeah, it's a country. It's a country thing. I mean, I think it's now there is a little bit of ethnicity in there too because
I don't know if this is real. By the way, I just want to check. But I've heard like in the past where they'll say, "Oh, someone like me, very pale skin, much more susceptible to skin cancer." That's backed by every form of data. And then I think maybe I'll get this disease wrong, but they'll say, I think it's lupus. you're more susceptible, or sickle cells, one of those two. You're more susceptible if you're black than if you're white. So those things, there's at least been data that's been reported over the years where it's like, okay, specifically these target different races. Right. So COVID, again, you were kind of talking more about the country, but less of that when it comes to actual races.
Well, no, I mean, there's like an independent effect on African Americans, maybe on Latinos too, but I don't know if when I say independent effect, I mean, that means after controlling for other things. So after controlling for metabolic disorders like diabetes and obesity, is there still an effect, race effect? There is for African Americans. I don't remember if there is for Latinos, but so you do find those sort of effects sometimes in when you're looking at epidemiological data, and COVID's going to hit African Americans. There is this independent effect that's going to hit them harder. It's going to hit obese people, diabetes, people with diabetes, and of course older people. Older people are going to be more susceptible to everything, just because of their depressed ability to fight things off.
Yep.
And they also are more likely to have comorbid conditions, maybe less likely to have obesity. You don't see a lot of really fat old people, but that tend to start losing weight when you get older. But
or they didn't make it there. Unfortunately.
Right, or they didn't make it there. There's you hit this thing in my field is there's no fat people in nursing homes. I mean, there really aren't. If you go to a nursing home, everybody's frail and skinny, because they don't make it there.
Yeah.
So that's part of the issue. And that actually was one of the things that confounded a lot of the research, because, usually with viruses, they affect everyone kind of the same way. But we see COVID coming in and having these different effects on people. And that's one of the things, not just this effect, it's not even a reliable effect by obesity. You don't say if your BMI is over a certain amount, you're going to die from COVID. That's not true either. So it's such a different virus in terms of how it affects people and who it kills versus who it hospitalizes and who it doesn't, and who it remains asymptomatic in. It's really hard. It was really hard to figure that out. But generally, people with metabolic disorders tended to fare worse with COVID. And so America as a whole, with its very high rates of metabolic disorders, has done worse than other countries because of that. Now, there's a lot of other factors too that have made us do worse than other countries, but that's one of them.
Well, couple things. First thing I want to ask about is the incentivization here, because we're talking about a lot right now. We're tackling a lot. I like this because it's very, very educational. But you had talked somewhere maybe 10, 15 minutes ago and talked about the fragmentation with the response and what the capabilities of the hospitals were going to be. So how much intake could they have over a certain period of time? What would a surge look like? Stuff like that. So the stuff we were really talking about at the beginning, and you've heard again a little bit over the past few weeks with it being winter again and some surges. But what about the fact that hospitals, because they maybe didn't get hit right away, but then set up like crazy and society set up like crazy to prepare for it, that then they weren't getting patients in there and therefore didn't have their beds filled. They weren't making money. People weren't even coming in for stuff they probably should have been coming in for. Yeah. And so then they get some patients. Patients die. Maybe they have comorbidities, they're obese, or they're old or something. And someone's sitting there and they have a mandated $13,000 check from the government if an already dead person, they just say, died of COVID.
Right.
How much of that is, because again, I try to take everything with a grain of salt that I hear, because there's all kinds of political positioning and bullshit going on out there. But it does seem like that has been a trend to happen in at least some hospitals around this country.
Yeah. So, I mean, here's something to keep in mind about that. And I agree with you. The incentives are pretty strong. Hospitals, at least initially, I'm not sure where the policy is now, but initially some legislation was passed very quickly to give hospitals 20% more payment per a COVID admission.
And they needed it.
Versus a non-COVID admission. They needed it not just for that COVID patient, which does require more
Yes,
more resources, right? But also because of the lack of, as you alluded to, the lack of elective surgeries, elective diagnostics, elective CTs and MRIs, all the stuff, non-urgent, non-emergent stuff that they weren't getting anymore.
Yeah, some people had heart attacks at home and died because they're just like, I'll just let it go.
In fact, there was a news article in one of these organizations, New York Times or Washington Post, or someone published a story saying, the big fear here is not so much the COVID patients, but it's who's not coming into the hospital. And they had a graph that showed like the number of people presenting in the ER with heart attacks.
Yeah.
And that graph showed is a precipitous drop. And you have to think, okay, those people are not having heart attacks. There's nothing about the pandemic that's going to prevent somebody from having a heart attack. You're right. They're having them at home. They're literally having them and not calling EMS because they don't want to go to the hospital because of the fear of the COVID.
Yeah.
So you've got that going on. So hospitals are definitely suffering. So now back to your point, though. I think I've read a lot about this. There's this feeling, and it's been fueled by a lot of different sectors of society, that hospitals are sort of upcoding these cases to COVID cases to get that 20%. I think there's definitely some of that happening. But you have to remember that if you're a hospital administrator and you're of a certain age, you've lived through a period of time where the crackdown on healthcare fraud was astounding. Like Bill Clinton started it. He hired something like 1,000 new FBI agents who were just focused on healthcare fraud. And because healthcare fraud at that point was just out of control.
So it's basically doctors misreporting things to be able to...
Doctors, hospitals coding a patient. I mean, coding a patient as a COVID patient when they're not a COVID patient is healthcare fraud.
Yep.
The reason it's healthcare fraud is because there's a third party involved. There's a payer. Which is mainly the government. I mean, if it's a Medicare patient, that's anyone over age 65, you're committing fraud with U.S. government funds, and that's been so nailed down and locked down. Now, I'm not saying it doesn't happen. Obviously, it happens, and of course, it's going to continue to happen. You can never shut that down completely.
Yeah.
Because for a whole lot of reasons, healthcare is one of those things where it's very susceptible to fraud because it's very hard to prove things. But because of the crackdown in the past, I would be really surprised if there were a lot of hospital administrators who were consciously upcoding patients in large numbers as COVID patients when they weren't. Now, is it going to happen with a few odd patients? Absolutely. If it's a patient, honestly, I hate saying this, but if you think you can 99% get away with it, you might do it. But if you think there's if there's more than a 0.5% chance of getting caught, that's bad. In this day and age, you don't want to get caught.
The difference now is that there is such a societal push on this whole thing that, again, when people even question facts around COVID as far as not the legitimacy, but the severity of it, they get labeled a hoaxer now. Because there were people who were hoaxers. There still are. There's a lot of them now.
Oh, yeah.
And they're just like, no, shit's like completely not real. And I think it's different when you are just like, hey, there's a lot of things that governments are doing to take too much control. That's something I'm very passionate about. And I'm not afraid to body bag those guys for doing that at this point. But when it comes to like the virus, yeah, the data is the data. Like it's not good. When you have the whole media apparatus on top of it, though, talking about it like they almost it's morose. It's almost like they enjoy it. We have death counters on all these channels and everything, and they're constantly like, hey, stay safe. We have all these public campaigns and everything. I just get the sense people aren't going in there and questioning, oh, that wasn't a COVID death, especially when you have hospitals who are barely paying their bills, too.
No, that's
so
true.
it seems like more of a one-off situation.
Yeah, it's true. I mean, I think, but there is a little bit of this IRS effect, which is in the U.S. that your probability of being audited in the U.S. is extremely low, actually. It's a single-digit percentage, your probability of getting audited by the IRS. Yet, the number of people who report their tax returns, honestly, is something in the 80 to 90%,
really?
range. Yeah, I can't remember the exact numbers, but there's this huge disconnect between the actual probability of getting audited and the amount of fraud, sort of minor fraud that you might see in a tax return. I'm not talking about little things like you forgot to include XYZ, or you deducted the a piece of equipment here that may not exactly have been purchased for your podcast. Whatever. I'm not talking about little things like that, but there's this disconnect between the threat of audit and the actual sort of amount of misbehavior.
Sure.
And there's a little bit of that now, I think, in healthcare fraud. I think there's you're right. I mean, the chances of anyone coming by and second guessing you, especially after that person's in the ground, is zero. But the risk, it's like, I think, well, the argument with the IRS is that most people have heard that audits are horrible. It's like getting a triple colonoscopy at the same time. Yeah. And that's, and so they don't want to go through that hassle. And so they err on the side of being mostly truthful on their tax return. And I think my experience with hospitals is that's what they're doing with healthcare. Like they're going to err on the side of being mostly truthful with classifying cases, because at the end of the day, there aren't going to be a whole lot of hospitals that literally go out of business because of COVID. There are going to be some that are financially strapped, but I mean, you're not going to risk, you're not going to put everything on the line in a fraud case, especially given how some of those have been tried by a very aggressive investigative apparatus.
Sure.
You're not going to risk that. So I think that I think it's happening, but I think it's relatively minor in terms of skewing the data. So I think the concern is that hospitals are going to call that death a COVID death. It's not really a COVID death. That's going to screw up the numbers. I think it's definitely influencing the numbers a tiny bit, but I think the general trends in the numbers are still pretty accurate.
Yeah. The other thing that I wanted to touch on that is a very difficult thing for me to conceptualize, just because it's, I don't know if controversial is the word, but there are winners and losers in things, and there's a black and white with stuff that then leaves some people by the wayside and also props up other people. Mm-hmm. And when you talk about some of the comorbidities, yeah, if someone had cancer or something like that, and previously had it, like that's a comorbidity. They probably didn't control that. It's, it happens to some people, and you got to watch it, because in that case, obviously your immune system is more susceptible. But when you're talking about things like obesity that are maybe more common in this country than, say, a country like Sweden or something like that, these are things that people, and I hate to put it this way, but technically you become obese because you eat too much, right? So if you're obese and I'm not, or I'm obese and you're not, like one or the other, the person who's eating a lot more is going to have a lot more health problems and a lot more things happening to them. So it comes back to some of these civil liberties arguments, which, again, that's something we've talked about a lot on this show. But why should I change my life and everything I do because you have something that technically, by the definition here, I don't want to say you chose to have it, but you made decisions in your life that you could have not made to get yourself into that position that I didn't make.
Absolutely,
and so I'm not in that position.
Yeah.
What is the balance there?
That's a really interesting point. And I think I've heard that. I'm starting to hear that chatter with respect to COVID. Basically, hey, I've taken care of myself. Bring it on. I can get COVID. I might be down for a few days. I'm going to be back at it. I'm going to be fine. So why am I suffering? Why can't I travel around the world? Or why can't I go out and go to a party, or, go to a club? I'm in good shape. I should be able to do those things, right? A lot of people think that way. And there's versions of that with other things, like smoking was, that was an issue with smoking for a while. A little bit different, because people were like, once the data came out on how costly smoking was to the health system, non-smokers were like, what the fuck?
Yeah, why are we paying for this?
That's making my insurance rates higher. I shouldn't. Basically, it's a cross-subsidization scheme, right? It's a subsidy.
Yeah.
I'm paying, if you're a smoker and I'm not, I'm paying a subsidy to your health care.
It's really the
because
same
you
question.
and I are both paying the same amount, but you're going to need more, so it's going to be subsidized by me. I'm going to need less.
It's all relatable.
Yeah.
Whether it's the bill itself or how it affects your day-to-day life, it's all relatable.
Right. So COVID actually, interestingly, I'm glad you brought that up because it brought that out in a different way. Once the data started coming out saying that, unhealthy people are really what we need to watch out for, a lot of healthy people are like, all right, well then if you've got a comorbidity, and we'll explain to you what that is, if you've got that, then stay home. When you go out, double mask. Don't get on a plane. If you've got if you're at risk, if you feel like you're at risk, then you take care of yourself. The rest of us are going to go about our business. And I think a lot of people feel that. I think that describes Florida, basically. And that's also a very individualistic sort of every man for himself kind of thing.
It's a libertarian thing.
Yeah, it's a libertarian thing. Yeah. It's like saying, look, we understand it's a problem. And it's a shame that there's going to be some people who die. But why should everyone? This is a classic argument, right? In philosophy and political philosophy is, the sort of the good of the collective good versus the individual freedoms and liberty.
It's just getting warmed up too with this.
Yeah, I think it is. It is. And you could feel these touch points or flashpoints, I should say. And the whole Florida thing's a definite flashpoint. It's just all the shaming now too. Like, your fellow podcaster, Adam Carolla, was talking about, he posted a picture on Twitter of him cutting into a steak at a steakhouse in LA, saying, just getting trying to escape COVID for a night or something like that. And he was talking about it on his podcast. He got completely shamed.
If you want to go psychotic, go into Twitter comments. I don't. There are apparently a lot of these people in the world, but
I try not to get wrapped up in that. But yeah, they're out there, right? And they were just attacking him for going out and having a steak. And I think that's what we've become, right? We were doing that before, right? If you weren't recycling, you were getting, there's go on down the list. Like there's a lot of things we're getting shamed and canceled for. But I think that the COVID sort of interesting thing about COVID is it pressure tests almost every aspect of the economy, or not the economy, of society. So it's like if you've got a balloon and there's some pinholes in it, but it's not uninflated balloon, there's pinholes in it. You start blowing into it, you're going to start seeing where those leaks are, but you're not going to know where those leaks. You're not going to see those holes.
You can't see them.
Until you start blowing into that balloon. And COVID's a big blowing into that balloon, and we're seeing all kinds of fissures. There's racial stuff, the fact that COVID disproportionately affects blacks. Once we found that out, well, now if you're a COVID hoaxer, that's a racist thing.
Yeah.
You don't give a shit that it affects blacks negatively. You just
that's how we label it.
Yeah. And so, I'm not saying these things. I'm just saying this is what people
what people say.
People are saying, right? Yeah. So I think COVID has become this big sort of it's transcended public health, and now it's a societal thing. It's how do we deal with something that that we need to work together on, but also at the same time exposes all these cracks and problems that we haven't solved yet. And it's just made those things worse. I think, and again, at the same time, it's like this perfect storm.
Yeah.
We have a president who fans these racial flames too, and just like wants to stoke up all this, sort of hatred and vitriol at the same time. And so we had this pandemic come at a time when we were already, just like becoming unhinged about a lot of stuff that was, and I'm not saying unnecessarily, like there was a lot of the police issues and, George Floyd and all this stuff was happening at the right around the same time. I can't remember if Floyd happened during COVID or before COVID.
Yeah, Floyd was like 3 months in, but these were things, we saw it pile up. It wasn't, it's not like he was the first.
Right. There's a whole bunch of precedents to Floyd.
Yeah.
But the pandemic just kind of makes all that worse, and it makes everybody on edge, and it makes it, we're very quick to sort of to see things in the pandemic. Part of the thing also is that everybody's at home.
Yeah, that's the entire thing.
Nobody's out doing shit, and so everybody's just paying attention to they're maybe watching the news a little bit more. Yeah, and they're online more, and They're getting whipped into a frenzy by podcasts.
Yeah.
And they're whereas, but you think about it, we're going to forget about this pretty soon because it's been so long. But before the pandemic, you had a life, right? You'd go out with friends, and
it's very sad. You say we'll forget about that, but yeah, it's been so long.
We might. I mean, it's starting to feel like that right now. We're almost at the 1 year mark of not really being able to live our lives normally. So it's, we'll see, what happens. Like, I think the longer we go like this, the harder it's going to be to go back.
That's the thing.
Yeah.
And that's why I keep talking about the precedents here, and it puts you against the grain of the quote unquote science on some things. And the other thing about science is science has become the new religion in a lot of ways. There's a lot of people who got a fucking F in junior year physics who are on there spouting on Twitter like science is the greatest thing ever and we must listen to it. You have to remember there are agendas behind so much. So you have to, I mean, you're a data guy, and I think you made that pretty clear throughout this. Like, okay, what did the data sets tell me, and how can we best predict how this is going to go? And so I've seen a pattern of whenever we see things that look like it could have an uptick during this, regardless of the bungled response and leadership and all that,
Right.
Again, we thought this thing was lasting 2 weeks, 4 weeks.
Right.
By the time we were in May, we're like, all right, this was a colossal failure. So everything since then, it's been a long time. And every time we see one of these positive upticks, it's like, okay, well, we were talking about this. Now we're going to talk about cases. Okay, well, we said it was going to do this, but no, it can do that. We started off this whole thing with, no, don't wear a mask, to wear a mask, to, oh my God, you have to wear a mask. Oh my God, you're killing grandma if you don't wear a mask. And it goes on and on and on. And like, yeah, again, does the data seem to back that a mask is a better way to go, especially around people who, let's say older people who are more at risk? Sure. Yes, absolutely. I can't really argue that. But where do you draw that line of the precedent you set? Because when you say things, and you're a really sociable guy, but when you say things like, man, we're getting far along enough here that are you even going to remember what it was like before? That's terrifying.
Yeah.
And if you put on your tinfoil hat, and that's not what I'm doing, but if you did and you said, oh, well, it's all planned by all these people or whatever, well, that's a good argument for them, because they'd say, well, those people who are putting on the tinfoil hat would say, well, damn, it's almost like all these people in power want us to forget what that was like, because for some reason this is the best ends to them, us being inside, and this is how they want it to be. It's crazy.
Yeah, it is, and I don't know how I'm not sure how this is going to end, but it's another way to look at it is, are we going to learn from this? Are there takeaways from this that are going to make us better in any way? So rather than think about the negatives, think about the positives that could come out of, learnings from this. Well, we're certainly going to be better at pandemics from now on, I think. We're also going to be better at what happens when people storm the Capitol. I think, because people do learn from stuff.
Yeah.
For the most part. I mean, a lot of things we don't learn from, but I think that I think we're going to learn from this. And I think, but I think what the problem is, we're only going to learn from it if we take it very seriously and sort of look and see like what worked and what didn't. And that brings us circling back to what we were talking about before. Let's see. I don't want to write off. I'm not a huge DeSantis fan, but at the same time, I don't want to write him off, because I want to see how Florida stacks up.
Yeah, you want to see the numbers.
Yeah, against the other states. I don't think it's going to be that bad. And I think, the other thing going on here is like there's still, even with a year mark coming up, the year anniversary coming up, we still don't. There's so much that scientists don't know. So you were just talking about how science is not always what it's cracked up to be. That's true. But what happens when the science is not even there? Like, I mean, there's so many questions about COVID we still don't know. There's a lot of weird, there's the new variants, which are going to cause a little bit of a problem, but the mutations. But there's also this issue.
Pull that in just a little bit. Yeah, sorry.
Here.
Yep.
There's also this issue where it's not just the new variants, but the issue with transmission. So we have we have an abstract into a conference. We're going to do a presentation hopefully in sometime in the fall on this transmission issue, because how contagious is it actually? We know it's contagious, right? A lot of people we have a shit ton of deaths already.
Yep.
We have a lot of hospitalizations. We have a lot of cases. It's obviously contagious. It can obviously pass from one person to another pretty easily. But how easily? Like how much? There's measures of that, right?
You talked about the asymptomatic thing too.
Yeah, and the asymptomatic thing is really important too, because we don't know, for example, whether an asymptomatic person can give it what we don't know is what is the transmission rate different among asymptomatic versus symptomatic. We think it is. We think if you're symptomatic, you're going to be more contagious than if you're asymptomatic. But we don't know the extent to which. Like there's just already a year in, we don't know the answers to these questions. So until we can really figure out what's going on with those kinds of questions, those really disease transmission type questions, like they're really getting down to the nitty gritty. Like, for example, what's the chances? You and I are about 6 feet apart now, so we're being good.
Yep.
But what are the chances of me coming in today and giving you COVID? We don't know the answer to that question. We don't know the answer to that question. So I think that's kind of important, right? Why can people get together? You can.
Yeah, I would think it's pretty important. Yeah. And by the way, you tested negative for COVID.
Yes, thank you. I know the viewers are probably like, what the hell's going on with this guy?
I keep on seeing the cost. Like I'm going to be getting shit for this.
No, I had three negative COVID tests this week. I don't know if you know it was 3.
Yeah.
So yeah, because I came back from Miami with a cough. Of course, I was shitting my pants. Thinking, all right, I was in Miami. Now I've got a cough. Yeah. But all I had was a cough. I never had the fever. And but of course, I did the right thing, and I went and got tested, which wasn't easy. Now the urgent care centers are a little bit they're handy. You know, the ones that are on the corner and everything.
Yep.
They you can go in there pretty easily and get tested. So I got 3 tests.
Now, did you do the full up your nose job or the PCR?
I did that's the piece. The up the nose is the PCR. I did 2 of those.
The rapid response one, sorry.
Yeah, and then I did the rapid one too. I think the rapid one was in the nose too, I think. But,
I've never gotten a rapid one. I've only done the full PCR thing. So I don't really know how to do that.
I did the rapid one in the name of science. I didn't need to do it. I already had the 2 PCRs, but I was curious about the rapid one. Because the rapid one's supposedly less accurate.
That's what I was going to ask. Like I've been hearing that the thing that I seem to get from some doctors I talked to, anyone else I'm not really going to take seriously, but who knows if the doctors even know, was that it's pretty accurate if you get a positive, but it's not necessarily very accurate at all if you get a negative. That's right.
Yeah. So the rate of the way we say that in the space is if a true positive. Actually, the way we think about it is a false positive. There's a 1% chance of a false positive. So that means you have a 1 in 100 chance of your positive test being wrong. But you have get this, ready for this, 34% chance of your negative test being wrong.
Yeah.
That's bad.
Okay. Yeah.
Yeah. Why is that?
That's what I was hearing.
The reason for that is that, part of it's attributable to the coronavirus being a tricky virus, but it's mostly attributable to the fact that we basically gave everyone, you got 3 weeks to come up with a test because we fucking need a test now. Like back in February and March, not even February, March, we were in desperate need of good diagnostics because we had at that time, maybe it was February. I can't remember the timing now, but we didn't know who had this disease already. Like in other words, when there's a pandemic, we were talking about the nursing home in Seattle. Remember that? Everyone's there's a nursing home in Seattle that's got COVID. And we're like, shit, nursing home in Seattle. Well, we should be able to contain that. And actually with the H1N1 virus.
I had that.
You did? We were able to contain that pretty well. Like it didn't spread nearly as much as COVID, and
there were a lot of hospitalizations for that.
There were, but I mean,
it didn't
take the same. It didn't transmit the same as COVID.
I remember when I was, I guess that last week. Yeah, it was that last week of February. I sat down on February 25th. I have the screenshots. I literally took it afterwards, but. Some people were freaking out about coronavirus and everything and how this was all going to drive shit insane. I had a couple people freaking out about it. I'm like, all right, this is kind of crazy, right?
Yeah.
So I just went to the data. That's what I like to do. I'm similar to you in that way, but you literally do it for a living. I just love doing that. And so I went to the WHO and like the CDC, the best ones.
Yeah.
And I went and I compared the data we were getting, which was all out of China at that time, which turned out to be all bullshit. So, that's why the moral of the story was I was all wrong. But I compared the data out of China to the H1N1 because I'm like, oh shit, I had swine flu. That shit was terrible. And there were, if I remember this, there were, I believe, 287,000 hospitalizations between April 2009 and January 2010 in this country, and there was a death rate of 4.54%. And I'll go check my notes on that.
Okay.
But
I didn't remember it being that high.
That's what it's telling me.
Yeah.
But that was hospitalizations. So people who actually had it, I didn't go to the hospital.
Right.
I had it terrible. Right now I was a kid and I was in good shape, right? So I'm the least susceptible to actually have something terrible happen. But I was home I missed like 7 days of school for that.
Oh, wow.
It was a long time, right? So you have to remember there's a lot of people who aren't going in and actually going to the hospital for it. So what is the real death rate for that? But, with COVID, it does seem to be that overall it's more severe. And it also seems like it is less contagious because I know there's obviously a lot of fear around it too. So more people are more likely to go in there, but we've had a lot more hospitalizations over a very similar period of time at this point, than that number.
Right. Yeah. So, so there's a lot we don't know about COVID still, unfortunately. And so we're going into this now year 2 with a lot of unanswered questions and unanswered questions about the virus from a virology and medical perspective, clinical perspective. We also have a lot of unanswered questions about what's the best response. We still don't have closure on that. DeSantis is still going to take a lot of flack for keeping things open in Miami, and Cuomo and Murphy are still going to take a lot of flack for closing shit up here. I mean, it's or praise. They're both going to get flack and praise, and I think that's part of me, again, part of me thinks, all right, this is good. We're getting some experimentation, but part of me is kind of scared by that because if we don't know already which of these methods is going to work at this point, then we haven't learned much.
Yeah, I mean, again, it's coming down to the time we have to process this. And one of the things I do want to talk about in a little bit is the vaccine, which is another time-related question because, again, you don't see vaccines get produced inside of 9 months or 10 months, whatever it was. And so there's a lot of questions around that. And I think that's well-founded in some places, not well-founded in other places, but we'll talk about that. But the other thing is, because we are still alive in this, you do have that clear political divide of, well, I'm Team Cuomo or I'm Team DeSantis based on what your preferences are as to what they should be doing. One of the things I have noticed, though, over the past 2 months in particularly, as we started to get into the fall and into the winter, and I guess into the new year now too, is there are a lot of people who, I don't know, I'm sure the political affiliations are both ways, who have passed their breaking point. And specifically a lot of people in the business community who sell product, whether that be you're a service business like a restaurant or you have a physical product, hardware store, whatever it is, and they're just getting crushed by this. And maybe not so much in states like Florida, but in most of the other states around this country, especially in the states that have been ridiculously, without data backing them at this point, over the top, like a New York. And what's very scary to me is we've now reached this point where things are kind of coming full circle. So I'm going to make some generalizations here. I want to highlight the fact these are generalizations. I'm not painting everything the same. But if we were going to generalize, when there was a lot of anger at police officers in this country, which hasn't stopped, but when it was bad post Derek Chauvin and George Floyd, it tended to be liberals were very angry at the police and conservatives defended them, right? And it just, again, generalizing, but that tended to be what it was. And everyone, with George Floyd, everyone agreed that was terrible. That wasn't the point. It was like, then are we going to paint all the cops like this or are we not? Whatever. Now I am watching as we are past the point where all the PPP money ran out, however you say it, and past the point where people have had grace periods on their rents and their leases and things like that, and past the point where revenues down below a certain number are actually allowing them to stay in business. And there's a massive desperation. So my second generalization is, think of the average small business owner in this country. These tend to be people who built it themselves, or in their minds they did, however you want to say it, and they tend to more skew conservative. Now, it's not 100% at all, but let's say it's 70, 65, 70, more likely to skew conservative. These were the people who were defending police officers over the summer. And the thing about the police officers, they've just had a really rough year. They have to do their job, and their job is to uphold what they're told the law is. And so what happens when you have these confidential hotlines where people call up and report people and whatever? The cops get called. And the cops have to go there on the basis of, well, was this rule broken that I'm supposed to uphold? Yes or no? Okay, whatever. So you're seeing these videos online now, and I'm not going to put one on the screen right now, but I'll put some in the show notes for people to look at themselves, where these police officers are showing up to these businesses of people who should be like their supporters, and they're not supporting them because they're desperate. They're in a corner. They've had enough. And what's very scary is that the only thing I haven't seen is these people whipping out guns to shoot the cops, because they're getting physical with them sometimes too. It's frightening to watch. And so the reason I'm bringing this up is because, yes, at the beginning, because we were dealing with something so unknown and, again, zone coverage, the whole nine. Yeah, the lockdown, so to speak, kind of made sense, and like I was with it. And when it just continued to drag and then seemed to be where the goalposts moved over and over and over again, it got to a point where we did have data also on this disease, where we could see, like, okay, here are the age groups and here's the data sets of who's most likely to die and what those numbers are. I mean, there was a report, I don't know if you saw this, I've cited it a million times on here, but September 10th from the CDC. It shows very clearly, if you are above the age of 70, you have a significantly higher risk with this thing, which should be common sense, but it's pronounced. I mean, they have a 94.5% chance of living if you get it at 70 and above. The next age group below is like 99 point something. So it's a big jump. So we know that. But we also know that as a society of 330 million Americans, 335 million Americans, whatever it is, there are a certain number who, if it was all pushed out into the open, they're going to live or they're going to die, right? And it's not 90-10. We're not seeing a 10% death rate. And so all these people who spent 10, 20, 30, 40 years doing everything, getting up for work every day, living the American dream, working their balls off, building something. I mean, you're a business owner. You understand this. When that's starting to get stripped away, it seems like it doesn't really make sense. And so from the public health segment, which you can also empathize with, you're really on both sides of this equation. How much can you keep telling people to stay the fucking side?
Yeah. You can't, right? I mean, that's the short answer to that question. And with any virus, I mean, the bottom line is you can run, but you can't hide, right? Because that's an old cliche, but it really pertains to viruses, not just COVID. Look at the cold and flu season every year with flu shots and everything. We're trying to give everyone flu shots. Why? Because we think a crap ton of people are going to get the flu. How do they get it? Well, it just transmits. Not everyone gets the flu from going to clubs. Not everyone gets the flu from going to bars, and so the flu transmits quite easily. I'm talking about the regular flu. And it has for centuries, transmits quite easily just through day-to-day living, touching a eye. Think about it. We take all these precautions, right? But then we go and grab a door handle that a million other people have touched, or 120 other people have touched it that day, that door handle. And then you put your finger up to your face when you get home and you've got your mask off and you got it, right? I mean, you're going to get exposed to we were talking about my cough, which is just the remnants of a cold. Right? We've determined that it's not COVID, right? Just again for your listeners.
First cougher in here.
First cougher in here. Just got back from Miami. So how did I get that? Right? I was talking about this with some people. They were like, "How did you get sick if you're wearing a mask the whole time while you're down there and washing your hands all the time?" And I'm like, "Yeah, that's a good question, right? I got a regular cold from traveling, and it wasn't COVID.
Could have been the airplane bathroom.
Yeah,
I mean, it can be. Yeah. That's the point,
I got it somehow, right? I touched something, right? I touched something somewhere, and I got sick. You can run, but you can't hide. You can't hide from a virus that has any sort of, sort of above average transmission rate. Yeah. If it's something that's going to transmit fairly easily, there's no way you can protect it. I think you made this point earlier. You can go and hide in the basement for the whole pandemic and then emerge and then get it.
Yeah.
Why? Because you've built up zero immunity to it during that time you were hiding.
What about your immune system being inside all the time?
Well, so I mean, there's a whole science around immunity, right? Or not just immunity, but your sort of body's immune response and everything, and immunology, all the stuff that is really taken off in recent years. And the consensus is that the more you expose yourself to something over time, the more immunity you're going to have to it. Mm-hmm. So let the kids play in the dirt. That's the thing now, right? I remember when I was in graduate school, this is a long time ago, one of my fellow students had a baby, and this is the first time I was really dealing with friends having babies, because it just hadn't happened that much in my life. I've kind of avoided that that whole thing. So up until that, I mean, it eventually caught up with me. But I went over to her house to see the baby. She made me take off my shoes and wash my hands before coming into the house, and I thought, it's weird. It never occurred to me that we need to create a sterile environment around this baby. And then, you're watching, then smash cut to 3 weeks later, I'm watching the Discovery Channel, and some woman crapping out a baby on a pile of hay. And you think, oh, wait, is that baby going to succumb to severe sepsis because they were not born in a sterile environment? The answer obviously is no. So as humans, we don't need a sterile environment. We're supposed to get sick. And the thing is, we're supposed to get sick starting from when we're a baby and then continue to get sick through our lives. So by the time we get to be your age, we've got a decent immune system. We've got a bunch of things
too.
Yeah, you've got a bunch of things that are exposed. And then, but when you get to be my age, it's supposed to be even better, because that's when you need it even more, and then so on and so on and so on, and eventually it's going to catch up with you when you're a lot older because you're weaker and everything. But there should be this sort of linear sort of improvement of your immune system over time, because you keep getting exposed to different shit. Now, that's not going to protect you from a new virus like COVID, obviously, because weren't a whole. But although that said, there is a school of thought that there are a bunch of people who have immunity to COVID because of some exposure from the past that we don't know about. Like, that's the thing. Like, you can have.
What do you mean by that?
Well, in other words, there could be something that you were exposed to in the past that triggered an immune response in your body and that immune response is able to deal with COVID, even though it wasn't COVID that caused that immune response. I'm sure we're going to get a lot of hate mail and complaints from the virologists who are listening to your podcast, but the saying that it's just not scientifically sound what I said. And I'm, again, listening audience, I'm not a medical doctor, but I do know. I read the literature a lot, and it is entirely possible that you get exposed to something, your immune system creates a host response that's lasting. So that's why you don't keep getting chicken pox your whole life.
Yep.
And you've got this immunity not to COVID specifically, but to something similar to it that didn't cause nearly the same havoc as COVID. But you've got some sort of, and that could explain your asymptomatic patients, right?
Yeah.
Now, what about the asymptomatic kids though? The kids don't really have had time to, so it doesn't really explain that very well. But anyway, I'm just saying there's this is all stuff we should be thinking about, right?
Kids generally do better though with picking up the quote unquote bugs though. Not that COVID is a bug, but you know what I'm saying? Like if you or I got a cold even, it's more likely to affect us than it is a kid who's running around and playing all the time, so to speak.
Right.
Which is also, by the way, something they're not doing now.
True.
But, you talk about immunology, and the whole point of it is to build up a defense system for your body.
Right.
And that is literally what a vaccine is designed to do, because a vaccine is injecting you, and not all of them, obviously, but when you get your vaccines when you're a kid, tetanus, all that stuff, it's literally, or the flu shot, it's putting some of the virus, or not necessarily, but some of, I'm going to really mess up some of the science here and people are going to yell at me, but it's basically putting some of the bad shit in there in the form of a vaccine that's a controlled specimen to be able to teach your body, ooh, that's bad, okay, attack that if it comes in. Is that vaguely correct?
It's basically, it's just fast tracking rather than have that immunology come about through generations. You're just saying, all right, we're going to fast track this. We're going to shoot into your body a bunch of stuff. We're going to trigger a host response, and we're going to get you some immunity. But by the way, vaccine doesn't give you 100% immunity.
No.
It's not 100% protection. It's not the ace in the hole that a lot of people think it is. But it's going to improve your immune system. Somewhat artificially, in the sense that we're tricking your immune system into doing this. Where the sort of clean way to do it would be to, or cleaner way to do it would be to have been, just massive exposure over the years of your life. And so you've got some sort of innate ability to fight it off already. But we don't have that. So for certain viruses and certain bad ones too, polio and measles and all this stuff that, mumps and rubella, so all these horrible things that we vaccinate against, because they're so bad that we don't want to. We don't want that. Every man for himself kind of thing with those viruses.
We don't want that in our health system. Period.
Right, and with that, you see, that's those viruses. I mean, a lot of the rationale behind those vaccines was those things. Not only do they cause a lot of death, which is horrible, a lot of loss for families and things like that, but they destroyed the economy too. Yeah. I mean, those are diseases that hit working people, and
we know about that now.
Yeah. And so we absolutely did not want those diseases. We thought we could never advance as a country if we had those diseases. And you see a lot of developing countries that have higher rates of those diseases. They embrace vaccines. They have no problem with vaccines. There's stories about women in Africa who will take their babies and walk 100 miles to so that their kid can get a vaccine, because they know firsthand how horrible it is when a polio outbreak or something like that in their village. So so that's the story with vaccines. Yes, tricks the body into it fast tracks the whole thing. So I think an interesting story is coming out of this is the vaccine our ticket out of this COVID thing? A lot of people think it is, right? So a lot of people are saying, the people who are really, very cautious about the COVID are saying, I'll see you when there's a vaccine.
Sure.
You've heard that, right?
Yep.
So, so what's the story with that? Like a vaccine is going to help. Absolutely. It's not going to eliminate it, but it's going to make it so everybody has a little bit of immunity, or it's going to boost everyone's immune system a little bit and give everyone better chances of fighting it off. And if that's the case, we don't have to worry about people getting it as much. Yeah. And if we don't have to worry about people getting it as much, we can just relax a little bit and sort of go about our normal lives. So the vaccine sort of seen as a ticket that can sort of free us up and make it so that we can go back to our regular life. The problem is, though, with any vaccine, a lot of people have to take it. You need this sort of herd immunity through the vaccine. Yep. You need everybody on board with it. You don't need you're on Instagram. You follow memes, right? Mm-hmm. How many funny memes have there been about people who have taken the vaccine.
Seen TikTok?
Yeah.
Oh my God.
Yeah. It's crazy, right? There's a lot of stuff out there. It's funny, right? I laugh at it, even though I shouldn't
You
be.
have to laugh.
Yeah.
at this
But
stuff.
but the reality is, stuff like that, it takes a toll, and it sort of works on people's subconscious, and they start thinking, you know what? I'm not going to get the vaccine. I'm going to sit out, the first 4 rounds of the vaccine and see what happens with these people. And if they're okay, then maybe I'll take it. And that's the kind of thing, like we've done so well eliminating measles and polio because we've forced kids to get it as a requirement for doing anything, sports, school. If you don't have vaccines, you're not going to participate in sports.
And there's some people that call that tyranny,
Yeah,
which I am not condoning. I completely disagree with
all
that.
kinds of hate mail.
It is,
No, absolutely right. There's that a lot of people think of that as tyranny. A lot of people, that's the hill that they're going to die on. Like they feel really strongly about vaccines negatively. Yeah. But a vaccine's the only way out of something really bad like polio and measles. There is no alternative. So, is COVID like polio and measles? Not really, in the sense that COVID's hitting a different, like it's really, there's a lot of young people your age, and a lot of people my age who are unaffected by it.
Yeah.
They can go out into a club that's where everybody's got COVID and they can go home and go to bed and it'd be fine.
Yeah.
They'll either emerge with something that feels like a cold or they'll be completely asymptomatic.
Nothing. Yeah.
That's not the case with measles and polio.
No.
If you hang out with somebody with polio and spend the day with somebody with measles, you're going to get it and you're going to die, or you're just going to have permanent effects from it. Mm-hmm. So COVID's not quite like that, right? I mean, it's bad, no question about that. I'm not minimizing COVID. I'm certainly not trying to dismiss it as a serious infectious disease. It's a very serious infectious disease, but it's different than polio and measles and some of these other things that we routinely vaccine against. So, getting people to sort of getting them on board to sort of add COVID to the vaccine cocktail that everybody gets is going to be a tough row to hoe. And I'm not sure it's going to happen. Like, I think there's going to be certain people. Right now, you see this pent up demand. There's a lot of people. I've talked to a lot of people like, I can't wait to get my vaccine. I'm going to be the first one there. Mm-hmm. But what happens when that crowd gets vaccinated and there's still another 64% of the population who hasn't? That's
or when 2 people from that crowd get vaccinated and suddenly.
yeah, exactly.
I'm good.
Yeah, it's all right. I think it'll pass.
Yeah.
Well, there was a report actually. Just saw it a few days ago. It said some doctor got vaccinated and then was dead a week later.
Oh God! Don't do that. Don't do that.
And so my thinking from being
it's probably a 400-pound doctor who fell over of a heart attack.
Well, it could be, right? It could be. I haven't seen it. Kidding. I haven't seen the guy, but there's a lot of things that you can die from in the course of a week. Also, there is if it's a doctor who treated COVID patients, depending, I don't know which vaccine he got, but if he got the vaccine that has the sort of attenuated virus in it versus the mRNA one, mm-hmm. That's another. I don't know if we have time to get into that, but
we might not today.
Yeah, but if he got the one that has the active virus in it and he's been exposed to a lot of virus, there is this school of thought with Corona that there is this sort of viral load thing, right? So
yes.
if you've been exposed a lot, then you're more likely to be hospitalized and die from it when you get it. So that's different than some viruses.
How much does the data support that, in your opinion?
I think it's pretty good.
Yeah,
actually, yeah.
Because I've been saying that's like a big thing, and I don't want to be totally wrong about that.
No, you're not wrong about that. I think what we don't know is what are the parameters there, like what constitutes high viral load. So we've seen some healthcare workers. Oh well, not some. We've seen a lot of healthcare workers, but not just in the U.S., but Spain and Italy. Data from China sucks on that because it's sort of state reported. But in China, in Spain and Italy, we see a lot of healthcare workers died from COVID. Yeah. And so the question is did they just get an infection just like you or I might get an infection? And then they went home and disease worsened. They went back to the hospital. It's too late and they died from it. Or did did they succumb finally? Their immune system held up for a long time because you think they're using the protective gear and everything, but they're getting exposed, right? So
that's interesting.
Did they did their body say, okay, we got this initially? And then their body's like, smash cut to 12 days later, and their body's like, we can't keep the
and
fight
they've been working around the clock.
Yeah, we can't. You're losing. You're not sleeping. You're not eating. You're not giving us what we need. You're not taking vitamin D and all these supplements that now are highly recommended. Yeah. So you're.
Dr. Christo had me on vitamin D all
day,
every day.
I knew you were going to bring this back.
Had him on there, baby.
Yeah,
it's my guy.
This pod's turned out to be like a big advertisement.
It's a rolling ad for Dr. Christo.
So the viral load thing, right? That's yet another thing that COVID sort of mystified some people on. We don't really know a lot about that aspect of it and whether that's a real thing or not. Whether it is a real thing. I shouldn't say that. But we don't know the parameters. We don't know the extent to which that is the case. Like what point at which your body just says enough is enough.
Can you give me some data after this podcast? Can you just give me any data you have access on? Because I'll put that in the show notes for this.
Sure.
Just to, I mean, again, like it's all kind of real time because this is all brand new this year. But whatever we can get that we can look at,
if you after this, if you give me a list of things you think your listeners would be interested in, I can give you the links or whatever, and you can take care of it from there.
Beautiful. Well, the thing about the anti-vax or whatever you want to call it sentiment right now towards the COVID vaccine, it's twofold for me in how I think about it. And the first side is I've been very concerned about the overall anti-vaxxer movement prior to COVID that's going on in this country. And I need to check which disease it was. I'm fairly certain it was measles though, but before COVID happened in December, January, February last year, there was a measles outbreak in the Midwest. Just because you have it, so it was measles. Yeah, and I'll put the link to that in the show notes. But it was because there are enough people who have convinced themselves that somebody's trying to kill them with these vaccines, and we're all going to die if we get it, so their kids aren't going to get it.
Right.
And here's how I look at it. One of the most common arguments you hear is people will be like, well, why do we have so many cases of autism now? It must be the vaccines. I've never read one of those books, so I can't say I'm fully educated on it. But let me even if there's no scientific data to back that, let's say some kids did get autism because of the vaccines. I always say it's unfortunately, if it were my kid, I'd be devastated, of course, and I should therefore not be somebody who's involved in the decision making for the rest of the population because I'm emotionally compromised. Right. But if I lined 1 million people up in a line and I said take 3 steps forward, 2 people are going to fall and break their head open. 100 people are going to take 3 steps backwards. It's the law of numbers. And so you're going to have, it's so sick to say and like sadistic in a way, but you're going to have some people who have bad effects. It does not make the overall goal for society worse or not the best idea to do. It does. So I've always been looking at that going, this is ridiculous. And then you add the internet to it and, people talking to each other, forming communities. It's insane. Fast forward to this period, though, with COVID. And what alarmed me for a long time is a lot of really smart people I know who are not anti-vaxxers at all. They have every single vaccine, have nothing against them. Were like, fuck this thing, I'm not getting it. Or at least check me in a year or something like that. And I was like, oh my God, this is a problem. These people are insane. And then I actually educated myself on the absolute high-level basics of vaccine, I guess, processes, like how they're formed and how long it takes and what the test groups are like. And I didn't get anywhere near your level. But one of the common ideas is that when they're building these vaccines, building them, creating, inventing them, they're doing it with people who agree in test groups to be a part of it, but they track over time. So you give a vaccine on March 1st, just because like you need it to be done on June 1st, if you have to check that patient 18 months later, well, June 1st isn't 18 months later. Right. So there are long-term things that we can't see. Now, do I think this is something like I Am Legend where they're injecting everyone and we're going to become zombies in 2 years? No. Yeah. But I understand the concern from people who are saying, all right, I'm gonna just wait on this for a while, or I'm just not getting this, because they're pushing it to everyone so fast. It's almost like, I understand the government's desperation because supposedly they want this over with, but to build up trust, you still need time to go by to be able to say, like, hey, this works. And now you already mentioned it, but there's different types of vaccines, different companies doing it. People are always like, oh, who owns Big Pharma? There's all these conspiracies around it. And again, people sitting at home on the internet getting themselves worked up about it. So in your opinion, just based on what you know, and if you can't answer stuff, no worries, but where are we right now? How trustworthy is it? And this vaccine process versus other ones, how confident are you in it where we stand?
All right. Yeah, that's a good question. So, first of all, just to start off, I totally agree with you that the vaccine rhetoric is out of control.
Yeah.
Like, I think the vaccine rhetoric is disproportionate or out of sync with the science. Like, and that's been going on, as you said, this is not a COVID thing. Actually, there were big debates emerging years before COVID with regard to measles vaccines and to a lesser extent the other vaccines too. But I think measles is sort of the measles is the thing where there were outbreaks. There was an outbreak in the Midwest. There was an outbreak in Marin County, California, because there were a bunch of people in Marin County who just are anti-vaxxers for whatever reason, and there happened to be a large concentration of them there, and there was a measles outbreak. I don't think it was a particularly big one, but there have been bigger ones around the country. And I personally, and this is I come to this from the science, I'm 100% on board with vaccines. They are the single most valuable public health invention of all time. Second only to, they're close second to maybe, they're a close second would be potable water. Or separating potable water and sewage. Yeah. That had a huge impact on public health. But vaccines are right up there at the top along with those things.
I agree with you. Yeah.
So that's incontrovertible. So there are certain areas in medical science that are unsettled, I guess, for lack of a better word. Ironically, vaccines is not one of them. That there is no unsettled medical science on vaccines. I mean, you might be able to find a doctor, not Dr. Christou. I think he'd be on my side on this one. You might be able to find somebody to come in here and with a medical degree and trash vaccines, but it's going to be really hard to find that person. If that's a legit person who has a public career of any kind, they're not going to come in and spout, sort of falsehoods about vaccines. Yeah. So now, is a vaccine perfect in the sense of having zero side effects? They're going to have some side effects, but not autism. Autism is probably not one of them. There are some negative side effects to vaccines. People can have bad reactions to vaccines. They usually happen right when you get it, before you even get home. They're not. It doesn't happen 12 years later, like the autism sort of people are. When I say
is that
autism,
what they say?
Well, yeah. I mean, yeah, exactly. So there's some people that say that the vaccine sort of sets the gears in motion for the kid to be diagnosed as autistic when they're 11 or something like that.
There's a whole host of things, though.
Yeah. And the rates the fact that there's higher rates of autism now than before. Well, that can be said. Look at allergies. There was a time in history literally where nobody had allergies. Well, they did, but
they didn't know it.
We didn't know it. We didn't talk about it. Now, but also they didn't. I mean, also the rates were probably a lot lower too. I mean, yeah. I mean, so what's going on? There was also a time in history when very few people had asthma, and there was a time in history when very few people, if anyone, had obesity. So there's disease trajectories that we could talk about in a whole other podcast. That's more of an epidemiological sort of anthropological epidemiology thing. Like, why does our society now have all these diseases that we didn't have before?
And sometimes it's because they just couldn't diagnose it.
Right.
Like there's a lot of autism cases. You know how many people were born with autism in 1940 and don't know it?
Yeah.
I mean, half of Silicon Valley is some of the most genius people in the world, and they, they're on some of, and I'm generalizing here, but some of them are on the spectrum, literally.
Right.
Like it's a very odd, I guess, condition, and is that what you call it? I want to use the right words here.
Yeah, it's a spectrum. It's a spectrum disorder.
It's a very
condition.
odd thing.
Yeah, whatever you want to call it.
So the numbers can skew.
No, right. So it's incredibly hard. As a spectrum disorder. That means when we say spectrum, we mean that it can present itself in so many different ways.
Yes.
So let's go back to the corona vaccine. It's so I don't think there's any unusual risks with the coronavirus vaccine. Either one of them. The one that is sort of more of a traditional type vaccine, and then there's the new, molecular.
The traditional one is the one that has the virus in it.
Yeah, it has like an attenuated version of the virus, stimulates the immune response. Really quickly, the other one is sort of more of a sort of molecular sleight of hand, in the sense that it causes a cell to look like a coronavirus cell.
Is that the mRNA thing?
Yeah. So it looks like one, but it's not one, if that makes sense. But it bears some of the same characteristics, and so your body develops an immune response to it, but it's not actually the virus. So it's a trick. More so of the other one's a trick too, but they both work. I don't know whether one works better than the other. We'll find out. This is the first time an mRNA test has really been rolled out with in any large numbers at all. So we'll get some good data out of this. But
how do you say confidently they both work?
Well, because they're both FDA approved, and now FDA's made some mistakes over the years, for sure. The FDA is not perfect. I think there was a lot of pressure on the FDA in this case to approve a vaccine very quickly. But there was also a lot of pressure on the FDA to not unleash an ineffective vaccine that would give people a false sense of security around this virus. So the costs of, for lack of a better way of saying it, the costs of fucking this up were very high. So
they're also done. If this turned out bad, they're also done.
Yeah.
They're done.
Yeah. So the companies that decided to go in on this made a commitment, I think. And again, I don't work for either. Well, I full disclosure, I work for. I do consulting right now for AstraZeneca, and AstraZeneca is one of the vaccine producers. But AstraZeneca's vaccine is not one of the ones that's being distributed in the country right now. That's a Pfizer and a Moderna. I don't work for either of them, so I don't have any conflicts of interest here. I'm not trying to promote them in any way, like you are with Dr. Christie. Shameless. So he just loves the show, man. Unlike this guy, I actually have no conflicts of interest here. So those vaccines are, in my opinion, safe and effective because they went through the FDA process of approval. They did some things on the clinical trials to speed them up. Now the thing about clinical trials is if you throw enough money at a clinical trial, you can get it done quicker because basically it's a massively parallel operation rather than the traditional sort of linear operation. So you can get a lot of patients into the trial all at once. It's very costly, but there's a lot of money flying around. There's money from government. So, normally a company like Pfizer is going to develop a vaccine with their own money, their investors' money.
Well, that's another question, though. But it still doesn't change. It still doesn't change the patient data period. So yeah.
No, right. So you're right. There's no way to know what long-term effects there might be from this, but we can use simulation models, clinical simulation models, to see what the long-term effects might be. We can look for indications in a shorter time period that might indicate longer problems. We don't see any of that with these vaccines. So, and also that, both vaccine technologies are from from a virology perspective or immunology perspective are not that complicated. Like it's complicated for us and for people who are not in the field, but for people in the field, this wasn't like a massively complicated engineering feat, biochemical engineering feat. It was
just a brand new virus.
Yeah, it's a new virus. Yeah. And so these companies know how to take samples and convert them to vaccines. They know how to do that, basically. I mean, it's a process. It requires a lot of really smart people and a lot of equipment and a lot of resources. But it's not a new field altogether. The mRNA thing is a little bit new, but the mRNA thing is all just a different – basically you can think of it as a different technology to get the same result. It's still creating something in your body.
Simulating it.
Yeah, it's just a little more fake than the real one that has the actual virus. So it's I guess it's tried and true technology. It's been around for a long time, and so generally, so so you've got that sort of peace of mind that they're not. This isn't a whole new thing they had to deal with. It's just a new virus, as you said. So, and then you've got the FDA, team devoting a lot of resources to this. You've got the companies, Moderna and Pfizer and AstraZeneca and all the other guys who are currently developing drugs or vaccines that aren't out yet. You got them pumping a ton of money into this. And of course, they're also looking at their asses too. They want to make sure they don't get in trouble for producing something that's going to cause a lot of, class action lawsuits later on. So, they've got their lawyers looking at it. And so there's a lot of checks and balances here. So just because the president was pushing and pushing and pushing, wanting to get the vaccine out quickly, not just the president, but a lot of people were saying, we need to get the vaccine, The vaccine's going to be the ace in the hole. The vaccine's going to get us out of this mess. In spite of all those pressures, I do think that we wound up with some decent vaccines here. I don't think they're perfect. Well, they're not. They're only 94% or 95% effective.
But that's not
that's
far off
pretty
what
good.
the other ones are. I mean, measles is higher, but some of these vaccines that we get, like the regular flu shot, is not even there, I don't think, right?
No. The regular flu shot's way below that.
It's like, I'm going to get a number wrong. I'm not going to say it, but it's way lower. I'll check that later.
It's south of that. The regular flu, the problem with the regular flu shot is that it's based on a strain that gets isolated, but there's usually more than one strain. It mutates, and it's all relatively harmless, but not actually. A lot of people die from regular flu, so I shouldn't say it's harmless, but yeah. So there are a lot of limitations to getting a virus right. But in this case, we had one virus. Well, now we've got some mutations, but putting those aside, we have one virus. We isolated it very quickly. We were able to look at it in a lab very carefully. And the vaccine development, you could argue, started immediately, even before this, this big initiative and government money and everything. These companies got on this right away. The smaller ones, especially like Moderna.
There's an opportunity.
It's like they're going to jump on this and try to. Everybody wanted to be first out of the starting gates on this, because at the end of the day, they're making money on it. I mean, this is not a public service that they're offering.
Well, that's the other big 500-pound elephant in the room here. You're dealing with quote unquote big pharma. And again, people sitting at home, a lot of time on their hands, all kinds of conspiracy theories. Big pharma owns Washington, D.C., vice versa, yada, yada. They're all in it for us. Like, they'll throw all this stuff out there. But this question kind of revolves around the fact that there are these enormous companies. You've named some of them, the Pfizers, the AstraZenecas, who do produce so many different drugs, and so many drugs that weren't even mainstream for mainstream conditions even 20 years ago. And now the data says more and more pump out. So people, they don't joke about it. They morosely joke about the idea that, we're pilling up society and everything, or we're pushing things on people to make these companies money. You work in this space, and obviously you're economically incentivized in the sense that companies like this will pay you to do work for them. So you want that to continue to happen. But you're also a guy, like, you're a straight shooter with me, and you tell me like it is. And I think that's really come across well today as well. So I know when I ask you these things, like, you're not going to give me some bullshit political answer, but how much of what you've witnessed working with some big pharma companies, or even, some mid-level ones, kind of revolves around the chase of being enormous and making a fuck ton of money versus actually trying to get to the root of problems and putting public health itself and the health of the individual at the forefront. Have you ever had moral questions around that?
Yeah, that's a really good question. Yeah, that's something that is part of being in this field, because you can't, first of all, you can't avoid the pharma company. If you want to work in this space, you're going to work for a pharma company at some point, because they're, that they're huge and they're everywhere, and there's, you can't survive just on, medical device companies, for example. Yeah. So anyone in my field has to work with pharma companies. What I've seen, and I've worked with a lot of different pharma companies, big ones and small ones, and I've worked with a lot of different people within those pharma companies. And I'm being completely honest. There are very, very good people working in those pharma companies. They're very educated. They tend to have advanced degrees because the companies need these more scientific type people. They're very passionate about their work, and they're very honest in their approach to that work. That's one thing. The other thing is the work that's done in a pharma company now compared to, say, 30, 40 years ago is heavily regulated. There's
red tape everywhere.
There's this ISO certification for processes. Clinical trials are registered and are very transparent. Clinical trial data is very heavily managed and controlled, and it's very hard to tamper with clinical trial data. It still happens, but it's much like, to my point before about healthcare fraud. There's sort of the pharma equivalent of that now, where some pharma companies been caught over the years doing some bad things, and consequently we haven't eliminated that, but it's happening a lot less because the consequences are so severe. So that's good. That's all good stuff. But the main point I think that you were making is, what about this sort of pressure that pharma companies have to make money, and how does that influence sort of what it is they do? I'll tell you, I'll be honest with you where I see it. They will often choose new avenues to get into, new sort of market gaps. Yeah. That where there's no drug for X, and so we're going to get in there and sort of create a drug for X, and that's the part where sometimes I part ways with them. What I don't like about that is there may not really be a need for a drug in that space. They will argue, well, there's some patients who respond to drugs, or let's say it's an area where there's a a non-drug. I can't think of a good example right now, but let's say it's something where there's a non-drug treatment. Mm-hmm. Maybe it's therapy or something like that, and the drug companies will come along and say, well, a lot of times that non-drug treatment fails. And so we're going to develop a drug for those people for whom the non-drug treatment fails. That's fine, right? But that's okay. But what about when the non-drug treatment works just fine, and you try to sort of put a drug on top of that? It may not be necessary. What they're trying to do is sort of create a market, and so they do this, right? But that's not the mainstay of their business. You're not going to There are very few pharma companies that I can think of that sort of thrive on that business model. Some of the big ones will have core drugs across a lot of they'll have a hypertension drug, and they'll have some a handful of cancer drugs, and then they'll have some heart failure drugs or whatever. They got this diversified portfolio. The big ones typically have that, and they might try to expand into a market where the need for a new drug is pretty minimal. But it's going to be a small part of their business, right? They're not going to build them. Now, there are some small players that have come along and tried to do things like that and gotten in a lot of heat for it. So, for example, EpiPens. Did you hear about that controversy?
Oh my God.
Everybody.
What happened there?
Well, the thing, EpiPen used to be just, I forget what company handled EpiPens, but they sold it. The buyer of the EpiPen redesigned it from a cylindrical tube to an oval. The cross section is an oval. I don't know how you say that. I'm blanking on that, but it's an oval shaped tube. That's all they changed in it, and they increased the price from like $120 to $600 per pen. No other reason on earth to change the price of that pen. Except for money.
It's money.
So. I mean, that was a stupid thing. They got I don't know if they didn't get in trouble for that because that's not illegal, but they got incredible backlash.
Yeah, the PR campaign.
Yeah, it was a PR nightmare. In fact, I was at the Forbes Healthcare Conference in New York City. It used to be held every year in New York City, and it would be like this big sort of think tank kind of thing where groupthink thing where all these experts would come in. It was a really great conference. I hope they can get back to that soon. But the CEO of the company it was Mylan? I can't remember.
That sounds close to it.
The new owners of the EpiPen.
Yeah, I'll stick it in the show notes. I remember this.
She sat literally in the hot seat. I give her credit for this because she sat there and endured just blistering criticism over what she did. And interestingly, the criticism was not so much related just to the EpiPen, but the sort of negative effect it had on the industry. It affected everyone. So even though there's just that one company that did that, it negatively affected a whole bunch of pharma companies because it's just bad. It's not all pharma companies act like that. And so, it's that kind of thing. Like there's always going to be negative stuff around pharma companies. And I think it's always because there's some bad apples like these guys. I want to say it was Mylan, maybe it wasn't, but those guys just kind of ruined it for everyone, kind of thing.
Yeah, Martin Shkreli was like,
yes, Shkreli or whatever. He was a bad actor, and I don't know what he was trying to do, but again, you could argue that had pretty serious consequences for the whole entire industry, and that was just one. Nut job who didn't know what he was doing.
That's the negativity bias, though, too, in any of this stuff.
Yeah.
You don't hear about when the FBI foils a terror plot. They foiled it. That's their job. Right. Maybe they do it 10 times a day.
Yeah.
You hear about it when they missed one.
Right, exactly.
And then it's like, who's going to get fired? And it's the nature of society. It's how it is with powerful institutions. But it's a question that has to be asked just because people have seen the pill is the answer for so many different things, and it's taken out of control. It's put into kids and stuff like that. So they get mad at companies like this because again, these companies are trying to make money.
Right.
You remember? Did you know Tom Riley at all?
Tom Riley from the boxing gym? Yeah, of course.
Yeah,
I sparred with him many times.
I forgot about that. Yeah, so Tom, I used to talk to him all the time, and he was the global head of finance for Novartis Oncology.
Yep.
So at least he was more focused completely like on the cancer side, but all the different things that go into that, the regular maintenance cancer drugs that they rely on making money on that some people could give them shit for. The way I loved his approach to how he looked to invest into things because he wanted to be able, and I'm going to say this not in the perfect way he would say it, but he wanted to be able to take the drugs that he knew were longtime stalwarts that doctors needed for their patients going through cancer treatments where they knew, okay, Novartis is going to keep making this drug. We're going to keep iterating and making it better. And then we're going to make big revenues off that. He wanted to do that so that then he could be able to go for moonshots. Right. And say, all right, I'm going to go sink. There was one project he was telling me about, this CAR T therapy.
Yeah.
So he was like the guy bringing that in there, and he was just like sinking a ton of money into it. And he couldn't tell me how much money, but a lot, right?
Yeah.
And the whole point was, if I know I have my cash flows coming from here, maybe we can save the world doing something like this.
Yeah, exactly.
And I think that's a beautiful way of doing business, and also putting value in the hands of your shareholders at the same time.
Right.
It's being prudent.
Right. Yeah, and Tom's a great example. I didn't think of him
well.
I didn't think of him because I usually think of the pharma people I work with, and Tom I just sparred with.
Yeah, Tom, you punched.
Punching each
That's
other all the time.
That's a whole nother story.
And we actually, ironically, rarely talked about work. We talked a lot about boxing. So yeah, Tom's arguably a good guy, right? He's a super good guy.
One of the best guys I've ever met.
He's a great dad. You see him in there with his kids, and so that's the kind of person I like from working with Pharma. That I know most of the people I know are like Tom, like they're trying to do something good, and they are succeeding. And any of the big pharma companies, Novartis and AstraZeneca and all that, they've all got, as you said, like a stable of products that are needed, because there's always going to be people who, I mean, you can't have a world without drugs at this point. I mean, obviously we did at one time, but
life expectancy was lower.
Yeah, it was a lot lower. Yeah. So like certain things like breast cancer, for example, that's a great success story. It's a combination of diagnostics on the high-tech diagnostics on the front end, mammograms and things like that, biopsies and things like that, and good surgical treatment and improvements in that surgical treatment, and then good drugs on the back end on chemotherapy and other adjuncts to chemotherapy to keep it away. With the combination of those things, we've basically, I wouldn't say we've cured breast cancer. We certainly haven't cured it. There's still a lot of cases, advanced types of breast cancer you can't get a handle on. But we've brought that disease from something that was devastating to
it used to be a death sentence.
To something now that you're highly likely to survive, and not just survive it, but survive it with minimal decrements in quality of life. Again, for most people and not everyone. But another one, HIV. I think about this now because, we see commercials on TV for HIV drugs with a cocktail. It originally started as a cocktail of drugs. Now there's some single drugs that are essentially versions of the cocktail drug all combined. That disease, talk about a death sentence. That was a big time death sentence. It's not anymore. If you get HIV, you're going to survive if you get treatment. And chances are, most people won't even know you have it. You're not even going to show symptoms, on the exterior that indicate that you have it.
I mean, Magic Johnson's the best example we always point to, but yeah.
Yeah, but now there's, and he was sort of the first to sort of really, like everyone was like, whoa, why is he still around?
Yeah, he's going to be dead in a year.
Yeah. And now he's going to have a normal lifespan like everybody else because of these drugs. And, so that's another example. I could go down the list. I mean, there's a lot of examples of pharmaceutical interventions that have really changed certain diseases for the better. But as usual, there's with everything, there's always a few that I mean, there's a part of I feel very passionate about health. Not just healthcare as an industry, but health as in why we go to the gym and that kind of thing.
You're a nutrition guy, the whole nine.
Yeah. So I like the fact personally of doing as much as you can to improve your own health so that you don't need a lot of sophisticated medical intervention of any kind. I even though I pay the bills, basically I pay my bills with sophisticated medical intervention. That's what my whole career is really focused on, in public health and type stuff and things like that. But philosophically, deep down inside, I'd rather everyone work really hard to build up their bodies so they don't need any of that stuff.
Yeah.
I'd love
personal responsibility.
Yeah, I'd love, like, type 2 diabetes is an interesting thing to talk about there, because type 2 diabetes that's different than like type 1. You can be born with type 1. So type 1 is a different type of diabetes, but type 2 diabetes is something you develop over time. It's true that you can get type 2 diabetes and not be, obese and eating junk food and all that stuff. Like, you can still get type 2 diabetes. It's not just the disease of sort of overweight.
Yeah,
people.
which is a common misconception. Like,
right.
People don't know that, but
right.
Yeah.
But it is highly correlated with your metabolic health. Mm-hmm. And that includes your weight, but not just your weight, but the types of food that you eat. So if you're eating a lot of, carbs and sugar and worse is sugary carbs like sugary cereal and stuff like that. Like if that's the mainstay of your diet, you could develop type 2 diabetes. But then if you change your diet, you can actually reverse type 2 diabetes. And so it's a reversible disease to an extent. I mean, I think if you're too far down the road, it's a lot harder to reverse, but you can reverse it at a certain stage. And that's an interesting, that makes it, to me, a fascinating disease because drug companies were all over that. They make all kinds of diabetes drugs. And their rationale behind that, if they don't actually need one, but if they were to have a rationale, it would be, listen, not all these people are going to lose weight. Not all these people are going to reverse their type 2 diabetes because it takes a tremendous amount of self-discipline to do that. And they're not going to do it. Yeah. Well, you know what? They're right. The drug companies are right about this. They are right. So the drug company's philosophy is, well, if they're not going to do it, we're going to give them a drug that's going to lower their HbA1c and maybe improve some of their other symptomology.
Yeah, I don't disagree with that at all.
And they're going to be better off with our drug than without it. Yeah. And that's probably true, right? But me personally, I think, I would like to see those people reverse their type 2 diabetes through diet and exercise. Yeah. But drug companies are right. They're probably not going to do that. So the drug companies in a way are sort of cynical and in that regard. And you could even see it in the diabetes commercials. And there was a diabetes drug commercial, I mean. There was one that actually portrayed a guy who, he was a little overweight and, it was like one of those narrated commercials and the guy saying, like, I try to exercise, but who's got the time for that, and you show him like playing with his kids and everything, his kids crawling all over him and everything. And so, okay, that's a legitimate point, right? Like that's the way a lot of people sort of take a pass on exercise. They say, I don't have time. I can't in my schedule. I come home from work. I've got to be with my kids. I got to make dinner. And then I'm tired. I go to bed. When am I going to take care of my metabolic health?
I guess they didn't show him throwing the football to his son, but it's neither here nor there.
Right. So that's the that's the where drug companies come in. So they're the cynics. They're saying, look, you guys aren't going to get your shit together. So we're going to give you something that allows you to. Statins are another good example. Like, although there's some, I don't want to get into that because there's some controversy now on sort of the role of cholesterol and all that. But statins were, at least at one time, they were like that. They were like, look, we know you like bacon, so go ahead and have your fucking bacon. And we got a drug for you. We're going to give you a statin. It's going to make that cholesterol go away, and everything's going to be cool. I mean, that's the way it is, right? And that's, we can make the same jokes about the erectile.
I wasn't going to go there. You went there. I wasn't going to do it.
I know, but there's a drug for everything. There's a need. Yeah, there's a drug for everything. And I think, but the drug companies are the cynics in that equation. And I think as the cynic, you're often going to be sort of tarred as being the bad guy.
Yeah. Well, I'm not going to keep you here all night. Otherwise, I'd go straight into the biohacking end of things right now. But we won't go there. That's for another time.
Maybe another cast.
The one thing I want to ask you about before you go, though, we touched on it a bit earlier. I just wanted to circle back to it. Was basically like the telehealth era that's come in here, and you were walking through the example of the company you consulted for who was giving you personalized physical therapy routines and everything to do that would basically replace the physical therapist and allow you to do it on demand at home. What changes do you think are completely permanent that you've seen that have happened? And I mean, what's been the scope of this?
Yeah, it's interesting. We actually wrote a blog on this and have it on our website.
I'm gonna put that in the show notes.
Telehealth. Yeah. So I think it might be either our most recent blog or the one before that. I don't remember. You can easily found on our website. Yep. I think, and when we wrote this blog, basically the idea is that the pandemic essentially set the table for telehealth. Telehealth was there already. That was one of the things that came along. One of the sort of like modern technologies that takes advantage of connectivity and smartphones and so forth. Telehealth was on the leading edge of that for sure. But the pandemic really iced it. There were all of a sudden now, people were getting prescription renewals via telehealth. You don't have to go into the doctor.
Yeah.
People are getting simple things diagnosed. I was telling you that I was just texting with my doctor. That's a version of telehealth. So diagnostics, actually, I think the very first visit I had when I was sick in July was they called it a telehealth visit, and I had to pain in my abdomen, so I held my phone so she could see my abdomen, and then she had me push in certain places. She said, all right, move your hand down a couple inches, push in there. And I do that. And she goes, do you feel any pain? I'm like, no. She goes, okay, now go over here. Like it actually, I think to an extent, we did exactly what she would have done if I was in the office.
Yeah.
So, sorry.
No,
yeah. So, so telehealth absolutely clinched it with the pandemic. It is here, it's not going anywhere, and it's hugely valuable.
Yeah, and you've seen, forgetting some of the names of companies, but you've seen some things just skyrocket with this just because people start using it every day.
Right.
And the doctors start using it every day. And it's the same example like I was given with Diane earlier at my old job where, people, they just assume they had to do everything in person for a long time, and now they realize some things that they don't have to.
Yeah, exactly.
So
yeah.
It's like, COVID just kind of sped up this whole thing. But
yeah, it goes back to this access issue too, just really quickly. Like if you can do, how many more visits can you do via telehealth?
A lot.
Versus in office? That doctor can, I'm sure it's 2 to 1.
It's got to be.
Or more.
It's got to be.
That doctor going seamlessly, sitting at his desk or her desk, doing one telehealth visit for 12 minutes. The next one's 18 minutes, but they're back to back.
Yeah.
Seamless. The doctor's got the computer screen. Hopefully, again, this goes back to our EMR or electronic medical record issue. But hopefully, in an ideal world, the doctors can easily call up the next medical record. There's no admin person who needs to go and retrieve a paper file from a filing cabinet.
Yep.
So again, that's like, we could talk about that until the cows
we
come
could
home.
go all night. But listen, this was phenomenal. I'm gonna listen to this a couple times through myself because there was all kinds of data in here, and especially during this whole thing continuing to go on into perpetuity.
Yeah.
There is so much misinformation out there. There are so many voices who have no qualification to be talking about it, but do and make themselves sound qualified, so you don't really know what's real and what's not. You made the point in there somewhere about something else. I think it was the physical therapy thing where you're like, people, they could just go find the videos online, but they know, well, is that real or isn't it? And I wish people would do that when they look at their news and their information more, and they don't. But anyway, this was extremely helpful. Thank you for coming in. It's good to see you too.
Yeah, great to see you. Thank you for having me.
Yeah, it's.
I think this is my first time seeing you in the flesh since the pandemic, right?
Literally, yeah.
Yeah.
Yes, I guess like last January or February. Mm-hmm. But it's crazy how fast time went with this.
Yeah.
It's crazy. But I'm glad to see you're doing well. We didn't even get to talk about your mindset on running a business during this whole thing, this whole time and doing well.
Yeah.
Another time we'll talk about
it. Another time. It's I feel for all the small business owners, and it's not easy, but you just got to double down.
It's a crazy time, and some people are able to handle it. Others, through no fault of their own, aren't. And
exactly.
I don't really know what to say. It is sad. It is sad to see people, I will say, who have, especially ones who have built something for a long time, just get crushed.
Oh, so, it's horrible.
Yeah. Hopefully we're almost done here, but I'll let you get on the road here. Thank you, sir. Pleasure having you.
Thank you so much for having me in. I loved it.
All right. Well, we'll do it again down the line.
Sounds good.
All right, everyone else, you know what it is. Give it a thought. Get back to me. Peace.